she is going to be assuming a role over there and part of the leadership team to make sure kids that the state does what it needs to do to improve mental health services for kids in foster care. And Luann, you want to say anything about your new job and what you'll be doing?
Well, first off, just thanks to all of you for being such great partners, getting the consortium kicked off at a time when we got started and then the nationwide or worldwide pandemic hit us. It's just been such a joy to be a part of this from the beginning. And, you know, we've had our struggles and our challenges, but we have a lot going on. We've got a lot going for us in terms of just looking at the data, all the successes that we've made so far. And I appreciate each and every one of you who is out there working very hard in your leadership roles within the system of care for kids in Texas. And so just want to thank you for your partnership. And I will be headed over to the Department of Family and Protective Services. It is a role that was created by the state legislature during the last legislative session. And actually, Trina Ida was the first person to fill that role. And she was on our consortium's executive committee in that role. And now she has taken the role that Sonia Gaines left at HHSC. And so, as Dr. Lakey said, this is a group of kids that I just feel very passionate about. For me, this work is really, I call it soul work. I care very deeply about making sure that kids in foster care get a fair shake. And I feel like if I, in some very small way, can have a part in making sure that they get their mental health needs met, I want to do it. And so I'm going to go over to the department, and I am most certain that our paths will cross again because we're all part of this big children's mental health service delivery system in the state. And I am sorry to have to say goodbye to all of you, but I will say I will see you again. So thank you very much for all that you do. It's been a real pleasure to kick this off and get it going. Thank you.
Yay, Luann.
All right, very good. It looks like a couple of other executive committee members have joined us. I think Dr. Martinez has joined us. Dr. Alam has joined us. If anybody else has joined us, that's part of the executive committee, if you'd let me know. Otherwise, we'll just go ahead and get.
Hi, this is Sue Shell. I'm here.
Okay, that's Sue. I didn't see you. Thanks.
Thank you.
Anybody else?
Hi, this is Dr. Amador.
Dr. Amador? Okay, very good. All right. Well, why don't we go ahead and get started? I don't think we're going to use all the time. I need to finish this meeting probably by at least 1:30 for some other things that are taking place. I think that's reasonable. But we have an important agenda, a lot of things we need to talk through as we get ready for the next fiscal year and for the legislative session. So with that, let's start off with the approval of the executive committee minutes from our May meeting. Take a minute to take a look at those. And then after you've done that, if somebody can give me a motion, we'll, in a second, we'll need to vote to approve those.
So moved.
I have a motion by Dr. Tominga.
Second.
We got a second. I didn't see who that was, but
Peter Thompson.
from Peter Thompson. Very good. Any further discussion? Hearing none, all in favor signify by saying aye.
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 Aye. Aye.
Opposed, nay. Did anybody abstain? All right, we have unanimous approval of the minutes from the last meeting. Next item is to have an update on TChat, and I'm going to turn this over to Rachel Chu.
Good morning, everyone. Let me get into full screen mode. So here is our monthly expansion report as of April 30th of this year. Very exciting. We are now officially covering over 4 million student lives. That represents 73% of the student population. We're active in just over 68% of all schools. Here, this is a new proportionate view of the previous slide, just so you can see how your HRI is looking overall, just in terms of percent of schools active. We have 96 schools with a planned implementation date, and those schools are coming from 4 HRI's catchment areas. Here's a view by ESC region. We saw 10 ESCs have increases in their active schools. The growth over time, just in terms of population and schools, continues to grow. And reasons for decline, the largest reason for decline does continue to be that the school has existing mental health providers, followed by districts that decline some schools within that district. Any questions here?
Before, can you go back to the very first slide?
Sure.
If we could. So right now, we're in the midst of the meetings with each of the individual HRIs and working on the current biennium's budget, but also planning for the next biennium budget. And one of the parts of trying to be accurate in our planning is figuring out how many schools will be on board for the next biennium. And so we've asked the different HRIs to look closely at the schools that are in their areas. Many of these schools, our folks have reached out to multiple times in various ways. We need to continue that work and see if there's other ways to reach out to those schools. But we're going to need to have as hard numbers as possible come this next school year. And so we'll need to get as close to final answers as possible for some of these HRIs that we've attempted multiple times to reach out to. And then, if, when we want to include them and make resources available, the other challenge is that we need to have as accurate of a prediction model as possible as we go to the legislature for how much funding we need and how many personnel we'll need across the state of Texas. And so again, would encourage our institutions to make some additional attempts this summer, but come this fall, we'll need to say that if we've reached out to schools multiple times and haven't gotten a response, then they're we're not planning to provide those services and gather the funds. We need the next legislative services session to do that. There are several large HRIs that we know will be coming on board or that may be expanding come this next year. And so again, congratulations to the HRIs across the state that have been working with those institutions for a while. I think one of the challenges for some ISDs is some of the ARPA dollars are going away. They have funded some of the mental health services in their schools. And with that, we may see some transition. Rachel, did I get that right? Anything you need to adjust in what I said? No? Okay.
Captured it.
All right. Any questions on that? All right, very good.
Well, I have one question, David.
Yeah, hey, Stephen.
Will you let us know at what point is we lock the budget in and we're going to stop reaching to an unresponsive district, and I guess then we would move them in essence to decline. What do you think that process looks like in terms of a date? Would that be by September 1, or we're going to leave it more flexible?
So I'm going to need to give the legislature our predictions of our budget needs in about September. We've been trying to work with the legislature before the legislative session related to what our needs will be. And again, that's the challenge and why we need to make sure we move these institutions. If we've really attempted multiple times to reach out to them and they have not responded, we'll need to move those into decline come end of this fiscal year. Now, the door's not closed on them forever, but we're going to have to make some predictions. We want to make sure this program is available to any school that wants this program in their school. And so if they reach out to us, we'll need to figure out how then we can time it into getting maybe brought in, whether that's next session or if there's other opportunities, try to bring it in. But we're going to need to solidify our numbers as close as possible to at the end of this fiscal year. Okay. Does that make sense, Stephen? Or Dr. Pliska? Okay. Any questions on that? Okay. And again, for those listening in, our institutions have worked for 4 years to reach out to some of the schools and have made good faith effort. And any school that wants to be part of this program, we've brought in. But again, after 4 years of reaching out, we're reaching that phase where we need to concentrate on the schools that we know that are in, and use that as our models for our budget going and with our discussions with the Texas legislature. Okay. Rachel, I'll turn it back over to you.
Okay. So this morning, we're going to be introducing to you all our second TChat 2.0 policy. This is on referrals and enrollment. Broadly, the policy covers eligibility for TChat services, appropriate referral sources, and expectations for referral processing. Like I've been doing, I'm not going to cover the entire policy. You all should have received a copy of that last week. But I did want to touch on the key changes that we're proposing in this policy. The first change that we're proposing is that only referrals submitted by schools and districts with active MOUs should be accepted. Now that piece of it is not new. Schools and districts without active MOUs, we shouldn't be accepting referrals there. But new, we are setting a new standard in terms of referrals from outside entities. So referrals directly from providers and referrals from community-based organizations should not be accepted. We really want to redirect back to the student's school for the school to determine an appropriate solution for that child's needs and the family's needs. We also, unless the child is homeschooled, don't want to accept referrals directly from parents and guardians either. Again, that should be redirected to the student's school. Dr. Martin, I see your hand. I'll take questions at the end. Our second key change for the referrals and enrollment, we want to make sure that we're triaging referrals at the time of referral. This work has been guided by a work group convened by COSH, and we had representation from every HRI, and those changes are currently being put in place for the beginning of next school year. Third, at least 90% of referrals should be processed within 15 business days. And if 60% of referrals cannot be processed within 20 business days for 2 consecutive months, that will trigger waitlist support, which will be provided by COSH and additional coordination with other HRIs as needed. And then finally, HRIs will be responsible for obtaining consent documents. We do recognize that this will be a change for some HRIs that ask the school to obtain consent documents and submit those at the time of a referral. We want to make sure that we're capturing an adequate picture of the need for TChat services and not just those that we can receive a consent for. Very briefly, our timeline. So after TChat 2.0 was approved, we began preparation of this policy and obtained COSH feedback and feedback from our HRI TChat leaders. today we're introducing this policy to you, and hopefully will gain your approval to implement next month. And then implementation of the policy will begin in August. Okay, I'll go back here for questions. Dr. Martin?
Yes, I had a question about CPAN to TChat referrals. Is it going to be acceptable to let the parents know that you're recommending a TChat, and then the parent can call, or the provider can tell the parent to call the counselor at their school to set up?
Yes, absolutely. And we do have some resources available. I know that some HRIs have prepared letters to send to the family to help facilitate that process. So that will still be permitted.
Okay.
Brittany?
Yes, on the 60% of referrals, if they're not enrolled and within 20 business days for 2 months, the wait list. So if you cannot get parental consent, sometimes we don't even get a response, so we don't necessarily get declining. Is that going to count? That's not really a wait list issue.
Yeah, so we do recognize that, reaching, processing 100% of referrals is not ever going to be possible because of reasons like that, that you mentioned, Brittany. And that's why we've set that standard lower than 100%. And these are things that Kosh has been discussing with each HRI, monthly, how every HRI is doing compared to that metric. So, we do hope that this isn't much of a change because we've been talking about it for the last year. Dr. Williams, I don't know if you have anything to add.
Not at the moment.
Did that answer your question, Brittany?
Yeah, I know that ours is one of those where we are already doing the consent documents as opposed to the school doing those, as some do. So I don't know if maybe with everyone moving to that, it aligns us a little bit more, because I know some of our referral time, it was a bit different because of that process. But okay. Thank you.
Dr.
But,
Plisk?
yeah, my understanding was the clock kind of starts running when you make that first phone contact. You've got a live parent who says, and then you want to enroll them and set that first appointment within that 20 days. If we call and we leave 3 messages and they never call us back, those are not in the denominator, so to speak. Is that correct? Or am I misunderstanding it? Because we always seem to be measured in the stats we get. The denominator is always smaller than the number of total referrals that have been in trade.
I'm going to pull up the policy right now. So referral processing, because currently in the policy, referral processing includes reviewing the information submitted with the referral and contacting the school liaison, triaging the referral, editing anything needed, contacting the parent within 3 business days after the referral is received, notifying the school liaison if we need some help contacting them, collecting that documentation, including consents, and then scheduling the appointment. So the way it's written right now, Dr. Pliska, those students would be included in the denominator. This would be all referrals received, but open to.
I mean, we can, I think that's, Laurel, correct me if I'm wrong, isn't that different from the numbers you're looking at us? You're starting, we get a subset of the people, which I assumed was from the first contact, but because we're not, our denominator has not been calculated on the 500 referrals we get a month, but like on 150 or something like that, which kind of corresponds to the number of people we reach.
So again, getting somebody from a referral to an enrollment is a multi-step process. We understand that. That's why we've always said that it's never going to be 100%. That we understand that there's lots of reasons for why, either because the family doesn't call you back, does call you back, but never gives you, I mean, there's, again, we know there's a number of reasons. That's why we've never said it's going to be 100%. But the idea is that we need to try to reach the families quickly, because this is a service that's for people that hopefully need services quickly. And that's why we've sort of been walking through this idea.
Well, yeah, maybe it's at 90%. So if you call someone 3 times in 15 business days and they don't respond, they've been processed, right?
Yes, yeah, so then you would
So you're
archive.
good on your 90%.
Yeah.
But now let's say you've got 100 referrals, 40 people never respond to you. Now you've got this 60 that you're working with. I was assuming 60% of the 60 is what you've got to get into your appointment within 20 days, not because you'll never make 60% of 100 if 40 people never respond.
Right, and those individuals would potentially become archived because you never reach them. Because again, we as a service, we can't provide service without parental permission. So if we never reach the parent, then they're not in the service. So yes, that requires we've allowed for teams to, have some, not allowed is the wrong word. We've talked about the idea that some teams want some flexibility as to when they would close out a referral. But again, the idea is that we are trying to get youth in quickly and try to prioritize those families and youth that do want the services, and we can get them to call us back, and we can get the consent form, then we can get the appointment scheduled. So I think that's the
word that Rachel just added removes all my anxiety, and it is the way I understood it being done.
Okay.
So if that fixes it, in my view, my concern, I think, was raised what Brittany was maybe concerned about as well. I have one other question on this, but I'll let other people ask if there's other people.
Go ahead, Steve.
Okay. I might, and I'll send some written comments on the issue of accepting homeschoolers. I'm fine with that. It's just that could potentially open the door to us being a completely public facing institution, because if we just got parents calling into the line, anyone could say, yeah, my kid's homeschooled, I want TChat services. So I think we need some kind of threshold of defining homeschool, or I just don't want that to be potentially read as really just throwing it open to the general public to call in. Because how do you prove that someone's homeschooled? Is my understanding, if a parent just takes their kid out, disenrolls their kid and says, I'm homeschooling, they don't have any documentation that they're homeschooling. And a parent who kept their kid in public school and said, no, I'm homeschooled, I want to, just do it, say it myself, could potentially be eligible under that policy. So I don't think we have time to debate it now. I'll send in some deeper thoughts, but I was just curious if anyone else had any worries in that area.
I'll make a couple of comments, Dr. Pliska. One, we're not requiring referrals to be accepted for homeschooled students or for private schooled students. So that's up to your HRI to determine if you want to do that. In the policy, we also have a definition for homeschooled students. So if that needs to change, please let me know.
I'll send some stuff to maybe think about it before we vote.
So I think this has been helpful feedback. And again, the goal will be additional feedback over the next month, and then come to this body at our next meeting and get it finally approved. But Brittany, if you have any other comments, anybody else has any other comments related to it, please provide that to us. And again, we want to make sure we get it right in a way that that you guys can use. And not put you in an awkward position, while still making sure that we have clear understanding of the goals and the what we're trying to complete. Brittany, anything?
In still thinking about this, and I know this is something has been worked on a long time, so there may be other reasons. But again, sometimes getting that appointment within those days, even if parents do respond, but it takes a couple of weeks to get them to respond. I don't know if has that been considered of counting that appointment time from parental consent or as separate measures. I know though that's still part of looking at processing with the to get to the consent, but just a thought.
Okay, good. Dr. Wakefield?
Yes, I am just gonna, this may be nitpicky, I'm not sure. I pulled up the services policy, which I know we're not reviewing until next month. But I was reading that one and it said we should be working with our LMHAs to coordinate referrals to and from. And I just wanted to make sure we're looking at the language in this policy and the language in that policy and I get the reason for it and I want to do that. But I want to make sure that the policy, looking at this language, should not be accepted from community-based organizations. That's clear when in another policy, we're talking about coordinating to and from with the LMHAs.
Okay. Good. Any other comments? So Rachel, you want to talk about next steps on it first before we go to the other two policies?
Yep, sure. So next steps here, as Dr. Lakey mentioned, we'd love your feedback between now and our next meeting. I'll make sure to respond to every comment before then and send out a final version that we'll ask your approval on next month. And if any of you would like one-on-one meetings with me, I'm happy to schedule those as well. So just let me know.
All right. You want to go to the next two policies?
Okay. So last month, we introduced our fingerprint policy. And today, we would like to facilitate a vote to implement this. So just a refresher that we're hoping to address two issues here. One, we do have instances where HRIs are asked to provide multiple sets of fingerprints for a single employee to meet state and local requirements for fingerprint-based background checks. And not all of our institutions are requiring fingerprints for a background check and checking those regularly. Here were the recommendations that we put forth. First, reduce the likelihood of duplicative fingerprinting by applying for NCPA contractor status through the Department of Public Safety to gain access to their criminal history database. If you all approve today, this recommendation will be optional for HRIs to implement, but we do strongly recommend that. Second, we'll be adding language to specific documents to ensure background checks are met. So PIAs with HRIs will be amended. If you all choose, you may make changes to your MOUs and other external facing documents. Third, we want to make sure that we're maintaining fingerprint-based background checks for staff, for all of our staff who have direct ongoing contact with students. Applying for NCPA contractor status may help meet that need for you all, but you all also have internal processes that related to credentialing that may meet that need as well. And then finally, adopt a policy to define these expectations. We did have some action items at the end of last month's meeting, and I wanted to circle back on those. First, we needed to determine if HRIs are subject to the state requirements for fingerprint-based background checks. And the Texas Education Agency did confirm that HRIs are subject to these requirements and considered a contractor. And then we also were asked to obtain a copy of the agreement for access to the DPS clearinghouse. And entity and user agreements were obtained from DPS, and those were sent to you all last week. So again, here was our timeline. We identified the issue a number of months ago and did some research, prepared our recommendations, and obtained feedback from Kosh and from HRI leaders. We introduced this to you last month, and today we would like to gain your approval to implement.
All right, very good. Any questions related to this policy? Again, we had good discussion last time. Sounds like somebody's trying to get in, but I don't see who that is. What's it? Dr.
Sarah
Martin?
Martin. Yes, I was wondering how this fingerprinting kind of feeds into the fact that to get your license in Texas, you have to be fingerprinted. How does it get in here?
Requirements for a licensure, those background checks are not shared with the school district, Dr. Martin. So many districts do not accept those results. However, you know, on a case-by-case basis, you know, we have learned that there are districts that may be willing to accept NHRI's attestation that all of its staff who will be working with students have previously been fingerprinted.
Okay, thank you.
Dr. Amador?
Thanks. Do they know what places they would send the clinicians to do these things? For example, is there only one place in all of South Texas where you had to go to San Antonio to get this done, or Houston? You know, I'm just wondering for us folks down here in South Texas where we might not have those major credentialing centers.
Yep, good question. DPS does contract with a statewide vendor to obtain fingerprints. The current vendor is called Identigo, and they have fingerprinting locations all across the state. So there should be a number of locations in your area where staff can go.
Thank you.
Dr. Williams?
So if a school district isn't requiring it, because most of them aren't, then we don't have to do it. It's only for the school districts that require it.
If the school district is requiring that you all undergo a fingerprint-based background check and previous sets of prints, Dr. Williams, are not acceptable to them, then the HRI would need to send their staff for additional fingerprinting. Generally, we want to make sure that all staff who have that direct ongoing contact with students are fingerprinted, and a criminal history check has been completed for them. If you all have worked with your districts and are not experiencing issues, and you're able to affirm that your staff have undergone those fingerprint-based background checks, then nothing further will be needed from you. If that's not a current practice, and districts are still requiring additional sets of fingerprints, then we want to make sure that those requirements are also met.
Okay. So this is a partnership with the school. If the school doesn't ask for it and your HR department already is assured they've done a background check, we're good.
Yes.
Thank you.
Any other questions? All right. Hearing none, does anybody have a motion to approve this policy on fingerprinting for the Texas Child Mental Health Care Consortium?
So moved.
I have a motion by Dr. Dominga. You have a second?
Second.
Second from Dr. Amador. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Aye. Anybody opposed signify by saying nay. Did anyone abstain? Hearing none, we have unanimous approval. Thanks, Rachel, to you and everyone for putting that together, and thanks to the consortium. A lot of good feedback over the last month. We want to make sure we get this right, and so really appreciate this seems to work. You know, actually going back, you know, this whole issue came up in our TChat summit about a year ago. It was an issue that was raised by the participants that we needed to figure out a policy on this. And again, thanks for putting it together, and then the feedback, and then the approval. So let's go to the next policy for school outreach and enrollment.
So again, last month, we introduced this policy to you all. Some key changes here, new expectations for moving unresponsive schools to a decline status. Dr. Pliska, you touched on this earlier when we were reviewing our statewide expansion report. We also are asking now for reasons for inactive status. Additionally, campuses that do not want services on site during the school day, we are asking that they submit a justification form just to let us know why those services, they're unable to provide those services on site during the school day. Expectations for background checks have been added. We're also asking district leads to enroll campus liaisons and maintain access for their school liaisons, as opposed to having the HRI maintain that access for school liaisons. And then expectations for non-public and charter school outreach and enrollment have been clarified. Again, private school students and homeschooled students, HRIs may, at their discretion, accept referrals from these sources. And private schools, if you all choose to partner with them, should be enrolled in trade.
All right.
And again, here's our timeline. So after TChat 2.0 was approved, we prepared the policy, got feedback, introduced this to you all last month, and would like to get your approval today.
Rachel, were there any changes that were made with feedback from the executive committee over the last month?
Not to the school enrollment policy.
Okay. All right. Any questions or comments? All right. Hearing none.
Dr. Reddy, I'm sorry, Dr. Leakey.
Yes. Hey, Olga.
Sorry, really quick question. Will there be a distinction in the data between unresponsive school / decline versus straight decline?
That's a good question, Olga. That's something we can build in as a reason for decline. We can add that to our monthly reports.
Okay, thank you.
All right. Any other questions? Seeing none, does anyone have a motion?
So moved.
Second.
Motion from Dr.
Second.
Papa, second from Dr. Tominga. Any further discussion? Hearing none, all in favor of passing the TChat school outreach and enrollment policy signify by saying aye.
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 Opposed, nay? Did anybody abstain? All right, let the record show that we had unanimous approval of that policy. All right, the next item on our agenda is a status update for the new and emerging Children's Mental Health Researchers Initiative. A lot of work has been taking place, and thank you, Nagla, for all the work that you and Michelle have put into making this, putting in the infrastructure we need in order to make this work. So let me turn it over to you, and if you can give everyone an update on how that's going.
Sure. So we have 47 applications that have kind of continued to the next stage. We are having the external reviewers are reviewing them right now. Many of them have completed all their reviews, and the completion of the reviews are supposed to be for the end of this week. Next week and the following week, we're going to do the group reviews. So again, the group reviews, the whole idea is to see how the external reviewers, we have 2 external reviewers that are looking at each application, just to make sure they discuss their thoughts about each application. We also have in-state reviewers. These are nonprofit organization representatives and folks who understand the Texas priorities, and they're reviewing it from that perspective. And so we'll have discussions during those group reviews, and we'll identify based on all the different aspects, the scientific merits of the application, the the priority of the area that they're looking at, the feasibility, and making sure there's geographic diversity and representation as well for those applications. At our next meeting, which is July the 15th, our next EC meeting, the plan is to come here and present the finalist and get a full vote on the full finalist list. I think as we talked last time as well, we've looked at dollars that are available, additional dollars, so that we can make sure that we accept as many applications that meet all those criteria.
Oh, very good. We've gotten several questions about how many people are we going to fund. The answer is I don't know yet because we need to see how a couple things play out. At the executive committee meeting a couple of months ago, we had an approval that if there's funds available up to $2.5 million in the current research initiatives that aren't going to be spent this year, that we can roll that in and on top of the additional, the $6 million we had, that'll allow us to fund more. We need to do some work over the next month to figure out what that number is, and so we can solidify the number of individuals. The other variable is that different grants are worth a different amount of money, and we'll need to see which ones are approved so we can figure out what the right mixture and then how many total grants are approved. The other thing I would add for those that may be watching is that we're really trying to make sure this is aligned with the needs of the state of Texas. And so we work closely with HHSC to identify what they thought were some of the major challenges in the state of Texas. And we've built into the review process 2 individuals that will be looking from that perspective of the needs of the state of Texas from agencies and local mental health authorities kind of viewpoint, in addition to the full scientific review so that we can get the best mix for Texas. Dr. Nemiroff?
No, I just wanted to give a shout out to Nagla, raising a entire new grants review program is not for the faint-hearted.
No.
And being able to herd all the cats that are the reviewers and getting them to follow the protocol, NIH is used to this. And we know that there have been other times it hasn't gone well in other arenas. So, looking forward to the results, but great job.
Thanks. Dr. Trivedi, I see your hand.
I second what Dr. Nemiroff is saying. I actually I did already a similar process for the state of California, and I think Dr. Leakey and Nagla and you all deserve a lot of credit. Without divulging too many details, I have to say you are setting it up beautifully. So my respect and compliments to you.
Well, thanks. We really have tried to learn the lessons for the state of Texas related to things like this. When you had conversations with CIPRET, conversations with a variety of other entities, made sure that we copied their best practices, trying to make sure we have a good IT system that will allow the fair review. And we're trying to make sure that there's boundaries here to make sure that that we spread the grants across institutions and not just in a couple of institutions. And so We'll be hopefully finalizing that soon, and we'll come to this group for an up and down vote of the entire recommendations. We don't want this group to have to say this one versus this one and have that conversation versus you can expect that we'll have that up and down vote. Again, that the number will be determined based on those things that we've talked about, is the amount of money that we can pull together from the other research projects and the mix of the different types of grants that will be funded. Any other questions? All right. Hearing none. Dr. Williams, let me go to you for the update from the COSH.
Okie dokie. Happy to do it. I don't know if somebody has the slides or if I'm supposed to do it. That part I don't know.
Rachel is pulling them up right now.
Oh, okay, there you go. Then this won't take very long. We don't have too much for us. So happy graduation for those who had people graduate. We had our fellows graduate, Dr. Lakey and team, last Friday, and so we're so thankful to continue to have consortium funding to have us have additional fellows. Next slide. Next one. So we continue to see some general growth within our CPAN overall consultation volume. We do anticipate a slump in the summer. That's just normal for, as we've talked about many times, for child mental health. People are on vacations, going and doing various things, both physicians getting well-deserved vacations as well as families. But we're still pretty pleased to see it was almost essentially unchanged between April and May. And you can see from 2023 to 2024, we have had some growth with our consultation volume. Next slide. So this is just looking at that over the last 3 years. So you can see that continued growth for our program from year to year, from 22 to 23, and now midway through 2024. Next slide. This slide again is looking specifically at our involvement with our child psychiatry, and I always want to walk it through so that we remember which of these different columns are. The top, which says total consults, is looking at the last 3 months of how many consultations we received in March, April, and May. This is the one right below that is the number of consultations above that include a child psychiatrist in the conversation. And this is, again, something that we're paying attention to. This is very in line with other state program access programs as far as the ratio of how often a child psychiatrist is getting involved in the consultation. So we continue to provide services. That's why our first person that answers the phone is, an LMSW or LPC, LCSW, so they can provide help with resources, referrals, and, not do medical management aspects, but many other pieces that are very important for primary care. The next is the number of times that a pediatrician, family physician, or, family medicine or family medicine pediatrician asked for us to find them a child psychiatrist. So one of the things we're really paying attention to is how often they are looking for us to help them get connected with a child psychiatrist. This is important because one of the things that we're all aware of is that why the access program exists is that there are not enough child psychiatrists. So we're really actually hoping to see that number possibly, kind of whittle down, as you can see from March, April, May. That is happening where they're asking for that less. The other piece that we're wanting to pay attention to is if and when a pediatrician or a family physician asks for us to find them a child psychiatrist, we want to have our child psychiatrist hopefully have a conversation with them. Not so that we wouldn't find them a child psychiatrist. Of course, we will continue to try to help them with that. But sometimes there's an opportunity there for our psychiatrist to do some education with that PCP in the midst of the request for finding a child psychiatrist, including that it may turn into a direct consultation for our service, or at least simply better understand what the ask is. And since we know the PCP and the family may need to wait weeks or months to see the psychiatrist, we can at least provide some anticipatory guidance, even if the decision was still to keep looking for a child psychiatrist. So those numbers are starting to creep up, which we're also happy to see that our psychiatrists are involved when those kinds of requests are being made. And then the final number down below is the total number of direct consultations that we did across the state each of these last couple of months. And you can see there that number is steadily rising. and we anticipate and hope that it will continue to rise more. Most of the time we do, when our physicians across the state do a direct consultation, the consultation itself lasts anywhere from an hour to 2 hours maximum. So we do a very thorough evaluation. This is obviously with parental involvement and permission. If it's a woman, obviously the woman's permission. These numbers here are specifically around child psychiatry. Dr. Wakefield will share things related to PeriPen in a second. But again, the idea here is that our goal is to provide a direct consultation when it's clinically appropriate to help guide that primary care physician in their ongoing care for the young person that they have done that consultation for. So after we do that 1.5 to 2 hour evaluation, our psychiatrist does a write-up. That write-up is shared with the PCP. And then we also close the loop with a return phone consultation to walk them through our recommendations from our findings and really help educate that PCP full stop. So it's a pretty labor-intensive piece, but in our opinion, it's very important, and we're happy to see those numbers are steadily rising across the state month to month. Next slide. We have some big rollouts within our vendor trait in the next couple of months. The one that is up here now is an engagement product roadmap. So this is a product development that Trait did for us and for other programs across the country to sort of help do some visualization of how to help us be better engaged with our PCP team members. So the first, there's 3 phases that we're going to have. The first one just released, which is the engagement insights, where we can see sort of how many PCPs are using the service, how often are they using the service, is there regional differences, clinic differences. So there's lots of different ways that we can break down those populations into different segments. Once we can look at those segmentations, we can also use that information to help further our engagement with those primary care physicians. And then the phase, and so that phase is done, which is the identify different segments. The next one will be able to engage and measure, so we can do different outreach and targeted outreaches for primary care physicians based on those segmentations. That will be released partly in July and then October. And then finally, we'll be able to do specific engagement processes and then track their track how well they ran. So if we did a particular outreach to providers who have not used service in 6 months, we would be able to see how successful that engagement strategy was. And that is phase 3. So I just want to let you know that engagement tools are now available for all the teams in that phase 1. And we look forward to having phase 2 and phase 3 available to our teams across the state. Next slide. TChat. So this is, again, the slide that you guys should hopefully be very familiar with. It's the number of referrals that we've had in the last 3 years, academic school years, I would like to say, for TChat. And as we always expect, we're moving into the summer months. We continue to receive referrals. So TChat does stay open during the summer. Our services continue to deliver care to families and youth, but those numbers do tend to slow down, quite a bit because families are out doing other things. And even when we have referrals, sometimes it's a little bit even harder to reach them because they're kind of in or out with their own sorts of things to do. But TChat remains open even during the summer. Next slide. So this is actually looking at the breakdown for this academic year when it comes to how many students are referred is the top line, how many students were enrolled. And that is a very important number because that's how many students we're able to reach and get a consent for care from a family. We will not see a child without getting consent from the legal guardian. And sometimes there's various reasons for why we can't get in touch with people, and all of our teams are working hard to minimize that as much as possible. But at the end of the day, TChat is a clinical service and we must get consent from the legal guardian in order to proceed. And then after they've been enrolled, then you can see the line below that is the students that have had at least one encounter with our TChat team. So that's what this numbers are looking at for you right here. Next slide.
Dr. Williams? Oh,
yes.
Sorry.
Go ahead.
Quick question. For the students served with at least one encounter, should that be just even closer to the student enrolled since they were enrolled and a consent was received? do you think that that data point should just be much more closer and aligned?
I think that we've improved over time, but I also would say that as a clinical service, I think we're all familiar with families, may say they want a service and then for lots of different reasons may not come to an appointment. So if a family does not show for an appointment, obviously all of our teams will do our level best to reach back out again to try to understand, sometimes maybe the child was sick, the family member was sick, other barriers. And so we will do our level best to reach back out and get them involved. But still, I mean, every clinical team knows that you will always have some level of no-shows, even once a family has made an appointment and is scheduled to see you. So I don't think they'll ever be on top of each other, but we are happy to see the gap is closing. Good question. Next slide. This is just the number of sessions and students served from month to month. And as you can see, it sort of makes sense that as we have more students that we're serving, there's more sessions that we're providing in any given month. Next slide. And again, this is our familiar slide with how many of the, what percentage of the sessions are provided by different types of clinicians. And again, the overwhelming majority of care that we provide in TChat is related to a psychosocial treatment, such as a psychotherapy. And also beyond that is also assistance with case management, which is not a therapy, but it's a very important element of TChat to help provide a way to help families get connected to care if they need it once TChat services are complete. And then a much smaller percent of the time do we have our physicians involved or our NPs or PAs. Next slide. So we are continuing to develop processes as Rachel's kind of been walking us through with procedures and policies, as well as trainings for elements that we need to sort of implement our TChat services as we make these improvements. We have continued to provide on-site support and consulting to teams. We're working to prepare for that implementation and coordinating meetings in the summer with HRIs and ESCs to facilitate those strong partnerships. And also to follow up to Dr. Leckey's point earlier with schools that may have been unresponsive or declined services, with that sort of timeline of September in our mind to moving people to declined if after multiple attempts, which by the way, there have been numerous attempts, but it's this last sort of effort in the summer that people will, some ISDs will move into declined for the time being as a result of that. And obviously the UT system has been doing an amazing job in this last couple of weeks as we start to get closer to our summit, which will be happening next Thursday and Friday in Austin. So we're very excited to be coming once again together as a team across the state for a TChat summit. Again, for the vendor trait, they have several things that they're working on. We have a referral dashboard that's being updated to help us manage the volumes of referrals that we have received across the state and help us with both tracking that more efficiently and providing data more efficiently. We've also been working with the internal evaluation team to have the surveys that they do at the end once care is complete sent out through the vendor instead of a separate way, which was a more time-consuming process. So we're hoping that will improve that process of getting those surveys out to families. They also have a schools insight dashboard that's available to school districts so they can see some information and data. And then as we talk about that homeschool enrollment process, we're finalizing requirements of how we will collect that data so that we will have it clearly delineated that this is a potential homeschool young person and family that was seen. Next slide. That's it for us for Posh, CPAN, TChat. We also have some PeriPan slides that are right after this one.
Very good. Any questions for Dr. Williams? All right, I don't see any hands. Again, thank you, Laurel, for all the great work that you guys do to support all these programs. Let's go next to Dr. Wakefield on the PeriPan network update.
Hi, we could go straight into next slide. So wanted to talk about PeriPan enrollment and where we are. We have 899 OBs, 164 OB clinics. As a reminder to everybody, the metric that we're following is our obstetricians in Texas, but we are also have enrolled our pediatricians, our family medicine docs, and nurse midwives in this program as well. But the metric we're following here is specifically obstetricians. And we could talk about all the reasons why we chose that if anyone has forgotten. Next slide. So just to look at our activity over time, we continue to really focus on our call volume and trying to get that up, trying to tell people about our service. We know that we're not even a year into being statewide, but we're moving closer to that year mark. So really working toward continuing on enrollment and engagement and making sure everyone is aware of the service that we have. We continue to see our called only once and called multiple times both increase. At some point, we'd like to see the call multiple times increase faster. So working on that engagement, reminding people that we're here. We'll talk about some of the initiatives of how we're doing that in a couple of slides. We continue to follow. I think we have broken down on a different slide. Yeah, let's go to next slide. Some of the breakdown of the other boxes. So this is when we look at consult activity, a recurrent question has been who's calling to PeriPan. So we wanted to break that down a little bit more. For us, 66% of the calls have been clinicians, with obstetricians leading that charge. And then pediatricians next, calling about mamas during well visits and there with babies, followed by psychiatrists who are taking care of pregnant postpartum moms. Maybe somebody gets pregnant, the psychiatrist is not quite sure whether to stop medicine or continue that medicine. And so we see those calls as well, and then followed by family medicine docs. Next slide. So in mirroring, I won't go through all of the different definitions here. I think Dr. Williams did a fantastic job in doing that. But mirroring our data for CPAN, we wanted to show how we are increasing over time and how we're focused on some of these things to really drive the outcomes that we want, which is increasing capacity for our frontline clinicians so that they may provide more timely and more adhered to care. Dr. Williams had said that it is our opinion that direct consults are very important. And the reason that it is our opinion that they are very important is that we have a study that had came out about access projects. This study was specifically about perinatal access projects, but it showed the driving force of behavioral change. If when you look across the services for access projects, we're really first, the most important and impactful service that the Access Project provided to drive change and to build confidence in that frontline clinician were the direct consults, and that ability to have had a psychiatrist say, yes, I agree, this is the diagnosis, and then here are what I recommend as next steps. The second most impactful was that clinician to clinician discussion between the psychiatrist and the frontline clinician. And so we want to make sure we're driving those behaviors as much as possible because those are the most impactful based on this study. So when we look at percent of our consults that are including a reproductive psychiatrist, that's about 36%. We would like to increase it more than that. That's actually in line with a lot of what we see across the nation. About 2/3 are referral based only, but we know that referral, or at least based on the study, that referral process doesn't drive the change. It's the clinician to clinician discussion. So we want to make sure that percentage is as high as possible. And then looking at those when a referral is requested, so that percent PeriPan reproductive psychiatrist involved in the referral request is 88%. So very high. We're excited about that. We'd like to get that as close to 100% as possible, where when there's a question about needing a reproductive psychiatrist, that the psychiatrist for PeriPan gets on the phone and discusses that with that clinician, so we can make sure people are getting to the right level of care, and we can help support that frontline clinician as much as possible. We're still working on driving direct consults for PeriPan, again, because we know that impacts change the most. Next slide. We continue to have our grand rounds schedule once a month as a statewide collaborative effort across all of the HRIs. And this is our next one coming up June 18th, so tomorrow. These are on the third Tuesday of each month from 12 to 1, unless you're in El Paso, and then they're from 11 to 12. But we are excited to continue to provide this and have great collaboration across our HRIs. Next slide. So wanted to talk a little bit about PeriPan collaboration updates. We are doing a lot of collaboration across different entities and with different organizations. We have partnered with ACOG, the American College of OB-GYN in Texas, to prepare a toolkit webinar that is live and available. You can scan the QR code to access. This will take you to the webinar, and which also has a QR code that will take you to the exact toolkit. I think we showed a little bit about the toolkit last meeting, where and hopefully you guys are telling people about that. I think it's really exciting. I saw a LinkedIn announcement about it as well. We will be presenting at the annual district meeting, ACOG district meeting, and the ACOG district for Texas is only Texas, because Texas is so big. So it's great to be able to present to them as our Texas OB-GYN colleagues there. That meeting is upcoming, and so we will present again to their executive council meeting. And we continue to collaborate and send letters out to OBs across the state to tell them about PeriPan. We are moving forward in the PCORI project that is called Pathways to Perinatal Mental Health Equity, or otherwise just shortened to Pathways. We are working together to identify the clinics across Texas that meet the requirements for this project. This is when I reflected on that research that came out of the paper that came out about the most impactful parts of our perinatal access project are the clinician to clinician discussion and the direct consults. There was another study done that compared that impact to actually helping the practice manage practice change, going into the practice and talking to them about when to screen, how to refer, when to call the Perinatal Access Project. And that is what we're doing with the Pathways Project. And that has actually been shown to be even more impactful. And so all of those pieces together can drive change and improve access to care for our pregnant and postpartum moms in Texas, which we're really excited about. So we worked with the Department of State Health Services to look at the maternal vulnerability index across Texas. This is the map that you're seeing here in the middle with the darkest areas showing the highest vulnerability. I do think data is always very interesting because we have some areas of the state that have almost no services and they're being shown as very low maternal vulnerability index. So you have to take the data into context. So we had meetings with the team about that, taking that data into context, and then identified practices across these regions that would meet the maternal vulnerability index and the number of births per year required for this PCORI study. And are starting engagement with those practices to see who wants to be a part of this study process. And then won't stop there. As we learn through this PCORI process, we will be working with DSHS and the maternal PQC, quality improvement collaborative to work towards rolling this out statewide so that any practice, even outside of the study period, can have this service, and the PeriPan knows how to deliver that practice change element of a perinatal access project. And then finally, we have TPS. So we are working with the Texas Pediatric Society. We have launched our Echo series. It started 6/11, so just a couple of weeks ago, and is ongoing. It will run until October, and this is focused on postpartum depression. So an Echo series targeted with pediatricians, focused on postpartum depression, screening, implementation, responding to screening, and just general awareness and education. I think the next slide has that, yes, the topics that we have for that TPS collaboration. You see there was an introduction to ECHO. We have upcoming an introduction to postpartum depression screening, screening tools and assessment, implementation strategies in a pediatric practice, communication and support for families, collaborative care and referral networks, billing and coding and reimbursement, and then how to address non-maternal caregivers when you're facing depression, and maternal well-being in general. So I believe that is the last slide, and I'd be happy to take any questions.
Very good. Any questions for Dr. Wakefield? All right. I don't see any questions. But Sarah, it's nice to see those numbers go up to, it was 108. We've gone
Yes.
up to about 100, went down a little bit to 93, and then back up to 108. So that's good.
We are excited about that change. We are taking lots of measures and having one-on-ones every month with our teams to drive additional engagement so that we can get those numbers up.
All right. Very good. Why don't we transition then to the next item? Again, thank you, Dr. Wakefield. But we have a presentation from Texas A&M University School of Medicine. Last legislative session, they were funded for a study regarding child and adolescent inpatient psychiatric bed capacity and what the needs are for Texas. And I think our colleague, Dr. Liberzon, was in charge of that. And I saw his name just a little bit ago. Dr. Liberzon, are you there?
Hello, everybody. Nice seeing all the colleagues again. Hi, David.
Good to see you, sir. Good to see you, Israel.
Same here. I'm happy to share some of the information about that. Unfortunately, I was too busy. I had an important presentation last week until the end. So I have a couple of slides just for your information to look at that while I'll be talking. Can I share that or not?
Yes.
Okay, somebody has to allow me to share that. Is there a way to do it?
I'm having my people look at it right now.
Okay. I think somebody allowed me to share.
I see your email.
Oh, no, that's not what I wanted. Just a second. I will unshare that one. That's stop sharing and let me open this one. And let's do again sharing. If I can do that. Okay. Share. Do we have something here?
I see it, the slides. Yes.
Oh, okay.
There, now you're
Wonderful.
on the screen. Yep.
Wonderful. Thank you. So, good seeing everybody. We have been approximately year plus ago, we have been contacted by a number of different organizations because the state legislator on one hand and the hospital association on the other hand, specifically Chat Children's Hospital of Texas, were wondering wondering, do we have enough psychiatric beds for children or not? I think it came to us, one of the reasons, because we had some local initiatives in around Bryan College Station. We were trying to increase the number of beds, inpatient beds, and so on. So a request came, and as a result of this request, legislator apparently decided that's important question that needs to be funded, and somewhere in October we got retrospectively funded, as you can imagine. as usually happens. So we have started our project somewhere in September of officially in September of 2023. And the idea indeed was to look on what are the needs vis-a-vis inpatient beds. This is kind of an informal thing that who we're supposed to report to eventually. And all the committees and the lieutenant governor, speaker of the house, and so on. And the idea was to really trifold in a way that we think about it. First of all, to understand what's the situation with the inpatient beds around the state. Then identify gaps in inpatient services. Now, when I say inpatient services, we a priori working with the funders and the constituents, understand that as a wraparound services means what needs to go in when the child is identified as requiring inpatient hospitalization, and the discharge, which is sometimes the most critical part, and understanding whether there is an issue of, as you all know, the discharge of the child from inpatient services is often dependent on what is available immediately after that, such as daycare, day programs, intensive outpatient and programs. So we're kind of thinking about it as an inpatient and wraparound services. So the first goal would be, of course, to see what is actually there. And I must tell you, I was surprised how difficult it is to get a good information about what is there in Texas. And then identify the gaps. Now, how does one define the gaps? It's a complicated question because one can say gaps is based on the needs of whom, some of the hospital will tell us we don't want any psychiatric beds and we don't want children's psychiatric beds because we're going to lose money on that. We'd never recoup enough money. So based on needs of whom, what is the request? And of course, one other way is to think about that as a benchmarking. And as you will see, the benchmarking will be a critical component of our work and identification of needs. So from these definitions, you will see why the steps that we're taking after that. And finally, as a third thing, identify steps that are required in order to bridge the gaps between what is there and what are the needs. We have been working with various constituents to see with whom we have to report. So the funding came in with expectation that we will be working together with Texas Health and Human Services Office of Mental Health Coordination. And probably the most critical one is a statewide behavioral health coordinating council. And we have established a close ongoing relationship. As a matter of fact, tomorrow we'll have our regular meeting with the TCMHCC, that's the State Behavioral Health Coordinating Council, and with Children's Hospital Association of Texas together, and we are meeting regularly with them to see what's on their agenda that is critical for our questions, and also update. They will be also one of the key recipient of our reports, and they are asked to roll some of the reports and data that we are bringing into their expected report at the end of this year to the state, and so on. Let's see if trying to, okay, let me see. Yep. So we were funded for 2 years. We have less than 2 years to work on that, but we are funded for 2 years. So we have to finish as much as possible by the end of the year one. And we kind of identified that will outline the current status, key questions, preliminary descriptive statistics, and proposed approaches for more in-depth work for the second year. And that will be continuously discussed with our partners in the process. The process will be on what is known and what is still need to be figured out. And as I said, the first and most critical part for us was to understand how many beds, how many admissions, because as you all know, some of the admissions with psychiatric diagnoses are not occurring on psychiatric beds. And some of it because that's how it's supposed to be, because they have also medical issues that needs to be addressed and so on. But some of it is simply because they get admitted to hospital that that doesn't have a psychiatric beds. And they are not, there's no psychiatric beds available to do that, and they're sitting too long in emergency room. Now, what's interesting that I can tell you already, and that's, I'm not giving any data and numbers right now, but because we're not ready, but I can tell you that readmission to psychiatric hospitals, it's almost a rule if the child with major psychiatric diagnosis was admitted to non-psychiatric bed. So if we just look on the time and we see them they get admitted to non-psychiatric bed, the child bed or special bed or whatever they have, we will find very soon within next 30 to 60 days readmission to a psychiatric hospital. Just FYI, that's not surprising to anybody, but I think this data is critical. This type of data is critical to bring to the legislator. The other thing that is critical to bring to the legislator is how do we or how does one think about the solutions? How does one address this issue, and specifically a geographic disparity in access to psychiatric bed for children? Because that's a critical component that we will have to address, and we are collecting all the possible information right now to do that. We would love to get another information, which right now looks like we will not be able to get, unfortunately, is to be able to track longitudinally the child from one admission to another admission to another admission, which in my mind is a critical information, but we will not be able to get it within those time period allowed, because in spite of the fact that this information is available in the state, simply because we will not be able to go through the all the agreements and signatures that are required in order to get this, because it's considered, because of the time and readmission, this data is considered to be privacy healthcare data that is identifiable. And because of that, and multiple systems that we need to get their checks, we will not be able in time in the next year to get this information. So we will have to assume that or make a decision based on what we have. Charlie, I see your hand.
I had a couple of questions, Israel. Thank you so much for doing this. It's really, really needed for the state. Two questions. One, are you distinguishing between child and adolescent beds, since there are a number of inpatient psychiatric facilities that have adolescent beds but not child? And then secondly, I assume that you are taking the sort of state hospital child and adolescent beds out of the equation, since they're not by and large acute psychiatric facilities.
Well, right now we're looking for all of them. So we're not taking anything out of the equation because the data that we get is include all of that. What about the ages? So another question is always the age, right, Charlie? So per definitions or the definition for the data that is available there on a state level is 5 to 17. And we cannot separate between those two, and which is very important. I think this level of granularity will need to be looked at the second step. But first of all, even for the general information between 5 to 17, with the question that we have, with geographic distribution and the specific characteristics of the population and so on, by itself, it will be a pretty challenging, it is a pretty challenging task. But I absolutely agree with you. That's why we said that we're going to have to look in the first step, and then we'll have to look on the second step, is to see what can we be more granular vis-a-vis ages other than 5 to 17. Because some of the data comes in from 18, 4, some of the later 8, 2, and we have to start harmonizing that across multiple databases. I'm sure that that's not exactly what you wanted to hear, Charlie, but that's what is there, and we are struggling to put it all together. So I don't know if I answered your question.
Yeah, no, it's a start.
Okay. So where do we got so far? We got a commitment to collaborate with everybody, and we're trying to, it's not just a commitment, we're basically trying to stay on them and they to stay on us on bi-weekly basis or monthly basis or weekly basis, depends on each group, and we're present there in their meetings, and we have meeting that we originate with all of them. We already shared some of those backgrounds with this coordinating council that I was talking about and human health services. We established shared files here at the Texas A&M that our partners can access to and so on. We created our own 4 groups. It's basically 2, 3 people, 4 people in each group. So psychiatry, mental health, community context and perspectives, and that's the group that does all the interviews for all the constituents. We have data management analytics group, and of course the administrative support. Identification of existing secondary data sources, as I said, was pretty critical here, and we started the preliminary analysis of that. I have a lot of table, but nothing finalized yet. We conducted more than 20 key informant interviews. It's still in the process. When I say interview, we interview people from hospital associations, specific hospitals. We call people, as I say, during the benchmarking process. We check other states that we believe are probably the most well, how would I say, organized to provide child mental health services around the country. And this is all in the process. And we're about, as I said, we supposedly at the 8-9 months, but in reality, we're only 6 months since we started, and we are moving on and trying to keep it all going and have some data very soon. So I guess that's probably the last slide that I have. And now the only other questions, if there are any, I'll be happy to answer.
I guess one quick question, Israel, from me. I wonder if there's value in you talking to the people that run the all payer claims database, and whether that would have the ability to look at some of these transitions of cares and readmissions. I know they're not up to where they want to be yet, but last time I talked to them, they were making significant progress in getting the data and being able to use it. Any thoughts on that?
They are one of our sources.
Okay, good, good.
Yeah, they're definitely one of our sources because, it's always follow the money, right?
Yeah.
And they have information, and that's exactly what we need to find and reconcile some of that data with the other data and try to figure out, where the right kernels of information and truth and not overlapping and so on.
Israel, one other question I had, which is, I can't imagine that you could do this analysis without an understanding of the emergency departments that are capable of evaluating children in crisis, because they're the portal for which admissions are generated. And I know that there's tremendous variability in the state as to the personnel in a general emergency department to actually adequately assess children.
You're absolutely right. We are acutely aware of that. We're also aware of the fact that that varies both geographically and so on. We probably will not have a chance to do it comprehensively, but we are already, some of our key constituents are exactly the people that you're talking about, the ER representatives that we're interviewing. And probably we will add that as a next component. Now, one of the things that we will, I believe that will vary geographically again, because I think that geography is one of the key factors that the analysis has to be based on, because the disparity are not around Texas. First and foremost, it's all confounded, right? Geography, financial situation of the children, their ethnic and racial distribution, and so on. So I think I'm using geography as a keyword to try to understand all those key factors. And obviously, as you pointed out, one of the key entrances to the child psychiatric beds is the emergency room. Sometimes, as I mentioned, some of them are not, some of them are getting inpatient hospitalization and then in non-psychiatric bed and then goes to psychiatric bed. Some of the direct referral to psychiatric bed from psychiatrist outpatient or from MHMR. So MHMR is one of our key constituents. The emergency rooms are our key constituents and so on, as well as the systems themselves.
Any further questions? Seeing none, thank you, Israel, Dr. Leberzon, and look forward to hearing more and seeing the final study. Thanks.
We'll be happy to. Thank you.
So looking at the clock, I think it might be good to take a 10-minute break and then come back. And then I think we have about an hour's left of work, and we can kind of power through that and then let people take lunch after that. So why don't we take a 10-minute break? Actually, I'll give you a little bit longer. How about at 10 till we will restart? Yeah. So yeah. So at 11:50 we will begin again, and we'll have to take roll. But please be behind your computers in 10 minutes. Thanks. Although the current slide says 12:50, it's 11:50 that we're going to rejoin, and I'll have somebody correct that in a second. Thank you.
Jennifer, I don't think you're muted.
Oh, yeah, I'm probably not.
All right, everyone, it looks to me like it is now 11:50. So if you would turn your cameras back on, I need to count heads to make sure we're at quorum, and then we will begin again. Okay. All right, I think we're at quorum. So again, thank you all for being here today. Next item on our agenda is the review of Safety A. And we have Dr. Piniciotti here, and I'll turn it over to you. Pinciotti. I probably butchered your last name, and I should have practiced that beforehand, but Caitlin, I'm going to turn it over to you.
No, that's okay. I think the way you said it is probably the Italian way to say it, but it has been Americanized to Pinciotti.
Pinciotti, okay, very
Yes.
good. Very good, I apologize.
Thank you. Yeah, so I am going to provide a brief update on Safety A. We're now in our second phase of Safety A, which is the expansion phase. So on the next slide, I can expand on this a little more. Next slide. So in terms of our pilot phase, which we completed last year, we had initially set a goal of training 50 PCPs in Safety A, and we ended up exceeding this. We trained 68 for whom we have data across the state of Texas. And you can see this has been a really wonderful collaboration with both the developers as well as HRIs across the state. And phase one was really focused on gathering pilot data on the need for Safety A and the feasibility and acceptability of Safety A. Next slide. So I wanted to just provide a little bit of the data that we found. We've now analyzed this and written this up in a manuscript that we plan to publish as well. I won't go through every single one of these responses, but just to give you a sense for before receiving Safety A, what was the need that our PCPs across the state had? And you can see that our PCPs indicated that they worked with patients who were expressing suicidal thoughts and behaviors or non-suicidal self-injury quite frequently. But importantly, 83% of them reported that they had not received sufficient training in suicide risk assessment and risk reduction or intervention, which means that there was a really great need to address this in this group. Next slide. We then asked our PCPs about the acceptability of the Safety A training. We asked them a series of questions, which you can see here. These items were all rated on a 1 to 5 scale, with 5 being very much. And you can see that overall PCPs found the Safety A training to be very acceptable, to meet their needs, and to increase their knowledge and skills related to suicide risk assessment and intervention. Next slide. We then wanted to know, is the intervention itself feasible to use? As a reminder, Safety A was originally developed for use in emergency departments. And so we really had to scale down what the Safety A intervention would look like within the context of a primary care appointment, which is sometimes just 10 minutes long. And so we elicited monthly surveys from PCPs over the course of 6 months. Of the 53 who completed those surveys, you can see we had over 46,000 total patient encounters. They estimated about 2,000 encounters with a depressed patient and about 153 encounters with a suicidal patient. In total, our PCPs estimated that they used Safety A 288 times over the course of 6 months. And that 42 of our PCPs used Safety A at least once. You can see the range is quite large. We had some PCPs who used it up to 26 times, and that equated to an average of about 7 uses of Safety A per PCP. This is both a really kind of stark statistic in terms of the clear need to address suicidality in youth patients, as well as really promising that the PCPs felt that Safety A was a suitable intervention to use in these cases. Next slide. In terms of feasibility of this Safety A training, I'll start with compensation. So in our pilot phase, we offered compensation for completing surveys and for attending all of our training sessions. And of course, we wanted to know how much did that compensation play into PCP's motivation to attend these trainings, since we knew that going forward, that wouldn't be an ongoing option. We had 31 PCPs who completed a final survey for us. And you can see that most PCPs indicated that they would have still attended Safety A training even if they had not been compensated. And as I said, this is really important because we'll no longer be offering compensation. We'll, of course, be offering CMEs, but mostly we're relying on PCPs to feel motivated to attend. And so this was very promising as well, that they weren't just attending because of the compensation. In terms of attendance, this is where we did see some issues with feasibility. So the full Safety A training course involves 5 separate meetings. There's a 3-hour master training, 3 monthly 1-hour consultation calls, and then a 1.5-hour booster and wrap-up training. And what you can see is that we had less than 30% of our PCPs attend all 5 of these sessions. And so this really highlighted, some flexibility that we need to have moving forward in terms of how we are going to continue to roll out Safety A. Next slide. So lessons learned from the pilot: there's a high need for Safety A. There's a high acceptability of the training. People found the intervention to be feasible to use, but the training process was a little bit less feasible. Fortunately, we still expect that we would have participation even without compensation. Next slide. So that brings us to phase 2. So in terms of the accomplishments that we've already had just since the start of this year, we have had 9 of our folks internally trained as Safety A trainers. So not just attending Safety A training as a PCP, but being certified to then train other folks in Safety A, as well as train subsequent trainers. Within these training cohorts that we've recently completed, we identified 2 local champions, and these local champions will be co-leading a scaffolded PCP training cohort with one of the developers of Safety A, Dr. Zullo, beginning in July, and they'll be receiving feedback, and then they'll turn around and subsequently give feedback to our other trainers who are conducting their own trainings, sort of a quality check. We are also planning our 3rd cohort of trainers in July as well. So we're going to have even more folks trained as Safety A trainers. And in addition, our amazing collaborators at TTU have developed a suicide risk assessment training that can be taken in tandem with Safety A training instead of or any combination. And the plan for that is to have that available come September. Next slide. In terms of next steps, we are working on our end here at BCM to finalize all the administrative tasks needed to really centralize Safety A and maintain it as an ongoing program. As I said, our first scaffolded PCP training will begin on July 29th, and as that lasts for several months, it will end on November 18th. The suicide risk assessment training, our first one, is slated for September 4th. We are still working out some of the admin and CME related details of that, but that is what we have on our calendar. And because we have our folks becoming trained as Safety A trainers, we're going to start having many Safety A trainings coming live beginning in the fall. Once we are able to kind of get our footing and have kind of a recurring process of these trainings, our goal is to have 100 primary care staff trained in Safety A per HRI per quarter. And I want to emphasize here too that this does mean staff, including not just PCPs, but folks who work with PCPs within their clinics, especially if those folks might be helping to assist in such cases. As I said, we have a third cohort of trainers that we are currently scheduling as well that's full. And in the future, we want to look to train CPAN staff who can support PCPs who call for consultation. So the idea is that if a PCP calls CPAN for consultation, they're working with a youth patient who's expressing suicidal thoughts or behaviors, the CPAN staff can ask them if they've attended a safety aid training, and if so, remind them of how to implement the safety A intervention, send resources, whatever might be helpful. And if the PCP has not attended safety A, then this would be a good opportunity to let the PCP know about upcoming trainings that they might be interested in attending. Next slide. Oh, and that's it. Wanted to keep it very concise, but things have been moving well so far in phase 2, and we're really excited to get back to training more PCPs in safety A.
Very good. Any questions? Carol, I see your hand. Let's go to you first.
Yeah, thank you. Thank you. That was a really nice presentation. I think the value of it is obvious, and it was such a good idea to do this to first do this a pilot to give you an idea of what you were working with. So now you talk about all these sessions, and that the greatest liability that you found was that people didn't do all the sessions. Have you thought of making a virtual training course where PCPs on their own, maybe they have one whole Saturday that they would like to do the whole course in, or otherwise one small piece a week or something, a kind of a virtual training that somebody could use on their own like this? That would be terrific.
Yes, thank you for that question. Actually, you made me realize that when I was cutting my slides down, I accidentally cut that really crucial piece of information. Since we learned that the 5-session training process was not quite feasible for all of our PCPs, we've been in discussions with the safety aid developers about different ways that we can titrate safety aid training to meet the needs of PCPs. And so what we've decided on is that we'll have different options available depending on the PCP in the clinic. So we'll still offer kind of that full course. If there's a clinic or a PCP who really wants to develop a lot of expertise and strong competence in safety A, then they can attend all of those. But we'll also just be offering PCPs and their staff the opportunity to attend just the master training, which is the 3-hour training, which would really introduce them to safety A and help them to learn those techniques. And that training does involve some role playing, so it's not purely didactic. So that would be kind of the next step down. And then from there, we are also working with the developers on creating just a quick 1-hour workshop. Obviously, the 1-hour workshop would not cover everything that can be covered in the 7.5-hour training protocol that's typical of safety A, but it might be enough just to get PCPs thinking about, how to work with this population, and maybe would motivate them to then want to attend one of the longer training options available. So there's lots of different options that we're developing to address that concern about feasibility and attendance.
And my suggestion was to make this virtual, make a copy of it that's virtual.
Yes, and all the trainings are virtual. And right, the 1-hour workshop would be likely something that would be pre-recorded.
Viduker, Dr. Trivedi?
Thanks so much, Caitlin. You did a fantastic job with the data. I think it is fantastic, and one of the things that you didn't mention, but you did already, and that is do due diligence on looking at all these other programs and realize, because after phase 1 or pilot, we all decided we need to review everything that's available And then I think you and Dr. Williams concluded that safety A is actually still worthwhile, better than the other alternatives. So that's the one thing that I think the group and the committee should know. We reviewed everything, or they did, Laurel and Dr. Pensiotti. And one of the things that I think we have to start thinking about as we move forward, and maybe get your thoughts on, and Dr. Williams can chime in, it is actually in some ways, because I've been dealing with this. You remember I brought this safety aid to this program in the first place. I think that it is wonderful because it feels good. On the other hand, the real impact is we are not measuring. And I think we have to think about how we want to incorporate that measurement. And that is a key task for us in the next round, because the measurement that I'm talking about is the measurement we presented is about whether PCPs are doing these things right. The real impact has to be whether the kids are reducing their suicidal behavior. And I don't think we are doing that. So I'd love for us, Caitlin, and we should talk on the side, to figure out a way to capture that. Because, you know, a lot of these things in psychiatry where it feels good to do, but we never measure the end outcome. Do kids then reduce their suicidal behavior? We are not measuring in this construct, right? Nobody is actually paying attention to what the kids are doing. We're just measuring what the PCPs did, which is wonderful. But so I'd love to get everybody's thought on it, but we need to be measuring what is really happening with the kids. And I don't think we have done that, and I'd love to be involved with that. So my 2 cents worth of comment.
Yeah, that's a great point. And something that, at least in the immediate short term, that we do plan to measure is the number of trainers that we have throughout the state, and subsequently the number of PCPs who are then trained in safety A, so we can have a sense for that and be able to report that back to the state. But I agree that.
But the impact is supposed to be on the kids, not on the PCPs, right?
Right.
And I
so
don't think we are even touching that. And I think we have to, otherwise it is one of those good hygiene things that everybody talks about, but we don't have the data on whether did we reduce suicidal behavior. I don't think we can say that from the data we have.
So CPAN as a program is focused on the education and upskilling of primary care. And so Safety A is kind of within that vein. We could argue that for CPAN, we don't find out, do they actually follow our recommendations? So I think that's a larger question that we could certainly take up in future conversations, but we really are focused on that education and training of the primary care team has been CPAN's focus.
Okay, so maybe that's not important. Okay.
Madhukar is raising an important point, and there are really two different issues here. One is, are the PCPs actually adopting the tool and using it? And then the ultimate and most important point, does it reduce suicidality? And so I think this is a conversation that we need to have offline about whether the consortium is interested in developing a program that might actually look at this in an appropriate clinical way to determine whether this intervention actually reduces suicidal behavior relative to treatment as usual. And that's something we can talk about offline.
And Charlie, I think you raise an important point, which is why, because I've spent a lifetime doing this work. And I think that we all tend to do things that on the surface look good. But we are witnessing in the US an increasing rate of suicide amongst teens throughout these last 15 years, despite all this. So that's why the question. So thanks, Dr. Pensiotti. I think you did a fantastic presentation. I didn't mean to question it. I just want to think of us having an impact. And I think it's an impact if we get PCPs to do the right thing. But the real impact has to be that we have to reduce suicidal behavior. And I don't think that the data we have actually answers that question.
Dr. McCollum-Smith?
Yeah, hi. So, Charlie and Madukar, I would love to be part of a group because I think that's a problem with our field as a whole, as Charlie was saying. I think we need to really think about how we do that because it's tough, right? But maybe not so tough, but maybe there's some screeners, but I would love to be a part of a group to think about that. That
I
be
would
phenomenal.
love your help because I think exactly my concern is we all feel good when we do these things. And if we don't change the reality on the land, then I don't know what we are doing. So sorry for the bias. Caitlin, I wasn't trying to question what you're doing. I just think that we have to be thinking about the next step.
Carol, let's go to you.
So Charlie, I agree with your point. That to discuss moving forward, like Madukar would talk about. On the other hand, that is such a gigantic question. I'm thinking of PCPs. Even if you have 3 PCPs in a whole city that get this training, to think that you could really modify suicidal behavior if you measured it, generally speaking. Can you just say a minute about what you have in mind?
Yeah, I think, we've made a lot of advances in measuring different aspects of suicidality, from ideation to attempts to plans. And there are various scales that have been developed, including the Columbia scale. John Mann has a scale, David Sheehan has a scale. They have not typically been applied to child and adolescent populations. And so we could do what we always do, Carol, develop a scientifically based study in which we assess emergency departments, right, in various areas, and determine who was exposed to safety A or any other kind of intervention and who wasn't, and see if we get a reduction in those school districts, in those hospitals, in those regions. So it's a long conversation, but it can be done.
Yeah, I know. We have a similar measure, Charlie, and you have used it in your studies. And I think that we got to do it if we want to make an impact. We can continue to do this, guys. But I think if we want to make an impact, we got to do that.
Let me go to Dr. Wakefield.
I'm sorry, I had to go see a patient briefly, and so I might be coming back, and this has already been discussed, but Dr. Pinciotti and Dr. Williams, I would love for you to weigh in here because the reason that we chose Safety A is because it is evidence-based in reducing suicidal behaviors in kiddos, but it had been studied in emergency departments. And now we are looking at how we train PCPs in this suicide assessment and response and Safety A intervention. And I do think, of course, it's really important to measure outcomes, but those outcomes are graded. And first, we want to make sure that people are doing the intervention, that they're trained in the intervention, and they're doing the intervention. And then we can start measuring these other things, but that it would be somewhat, early to measure these things before we are training and implementing and seeing if people are using the tools and doing the behaviors.
Exactly. I agree with you, Dr. Wakefield, and I think that is where the rub lies, right? We are not even measuring what is happening with the kids.
Right. Any other conversation? Hearing none. Thank you, Caitlin, for all the work that you're doing on this, and Dr. Trivedi and the rest of the folks.
Thank you.
Very good. Thank you. All right, the last item, I think it's the next to the last item, sorry. On our agenda today, we're going to have a review of the ARPA-funded workforce initiatives that our HRIs have been part of. And Sarah, I'll turn it over to you.
This is going to be a long one, so we might have to take a break in the middle when lunch comes through.
I think we're going to just move forward.
Oh,
We had a comfort break, and so we need to just move forward, and then we'll have the other presentation. Okay.
Wonderful. Well, hi, everyone. I'm Sarah McLaughlin. I am the ARPA project manager. It has been a little bit since we've taken a deep dive into the ARPA workforce expansions. So today, we're going to have some of the leads at our HRIs talk a little bit about their ARPA workforce expansions, progress so far, and vision for the future. And for those who are unable to be here today, at the end, I'm going to give a verbal update of those projects, their progress, and their vision for the future. So to go ahead and get started, I believe our first group coming up is the Texas A&M Health Sciences Center Postgraduate Clinical Social Work Fellowship, and that will be presented by Bradley Bogdan.
Yes, thank you, Sarah.
Wonderful.
So, hello, everybody. I'm Brad Bogdan. I'm a licensed clinical social worker by trade and one of the clinical faculty here in the psychiatry department at Texas A&M. Can bump on to the next slide. And so one of the ways that we have applied our ARPA workforce expansion money was to support and expand our postgraduate clinical social work fellowship. This is a program that the department started in 2019, which you'll notice is prior to those workforce expansion funds becoming available, and is a 2-year program for licensed master social workers, so folks that have completed their graduate training and are in their supervised practice period before gaining independent licensure. And it's designed to provide intensive clinical training and practice experiences directed at preparing them for independent licensure, as well as addressing workforce shortage issues within the state of Texas. Speaking from experience, we work in a rural area here. It is tough to find qualified clinicians and even tougher to find ones that have had robust training experiences. So as the department began putting this program together about 5 years ago, it was critical that we find a way to make sure that we had qualified professionals to practice in all areas of our work. The fellowship has didactic case presentation, clinical supervision, and practice elements, depending on the week and what's going on, usually about 4 to 6 hours of interdisciplinary instruction per week between those didactic and case presentation elements. We currently have 9 LMSWs in the fellowship, 2 LCSWS clinical supervisors who are clinical faculty in the department. And we're proud to say we're in the final stage of the CSWE fellowship accreditation process. That organization is the accrediting body for graduate and postgraduate social work education in the nation. And assuming everything continues to go smoothly this fall, we would be the first accredited postgraduate training program in Texas, as well as the 5th nationally. So we're very proud of that. Next slide, please. So, as I mentioned before, we are in a rural part of the state here in Central Texas. The School of Medicine had previously tried to recruit licensed master's level social workers to some of the programs in the school, but had never managed to be able to do it prior to 2019. Once we started the fellowship, we recruited 22 fellows since 2019. We've been primarily limited by just funding and infrastructure at various points. And it's been competitive. It's been a very popular training opportunity for folks to apply to. We've accepted about 1 in 10 folks that have applied and expressed interest. We've had 8 graduates over that time. 4 of them continue to work within the School of Medicine. 3 others are also practicing in Texas in health professional shortage areas. And all 3 of the LCSW supervisors that we've recruited since we began the program in 2019 have specifically not moved away or moved to College Station specifically to work as part of this opportunity. So it is not just the trainees that have moved to a rural area to practice, but it's also been a recruiting tool for more experienced professionals as well. Next slide, please. Something that I love to emphasize about our program is that it really supports all of the other consortium's work. And it's been really important to us here to make sure that we have qualified staff to fill all of the needs of the other consortium programs. All 3 of our current CPAN clinicians were initially recruited through the fellowship. All of our interventionists in the YDSRN and CTRN studies are either current or graduated fellows. We've had a significant contribution to our TCHAT program from fellows over its existence. And nearly all of the psychotherapy we've been able to provide through our outpatient clinic has been provided through our fellows. We have very few opportunities for folks to find psychotherapy with folks that are qualified and not in kind of a one-off private practice locally. And so we've become a hub for providing psychotherapy to a dramatically underserved area. Next slide, please. We've, specifically with the child focus of these funds, we've served over 450 unique child clients during the course of the fellowship, which has amounted to over 4,000 child and family sessions provided. Being that the fellowship has kind of existed longer than the funding, we've also served 500 adult clients, as well as have trainees continue to take some now for the well-roundedness of their education, and have provided a little over 4,000 sessions to adults as well. Proud to say that 100% of our graduates have passed their clinical licensing exam. That far exceeds the national rate, pass rate for that exam to gain independent licensure. With the same infrastructure, we've managed to support 25 graduate students in various mental health disciplines, 18 of which are or were attending a public college in the state of Texas. So for no additional funds, kind of that additional infrastructure has provided really good training opportunities for students, which has helped to build our pipeline. Of our 9 graduates, as I mentioned before, 3 currently work on consortium projects, and 8 are currently working as clinicians in health professional shortage areas in Texas. In terms of just some subjective feedback of the training opportunity, all of our fellows during our recent accreditation process endorsed the program positively. That was anonymously an anonymous survey, so if they didn't like the experience, they would have had a chance to say so. But we're proud to say that they have enjoyed this process and found it valuable. In terms of expanding this, continuing this, making this useful for other places, we believe this is a replicable system. A lot of the things that we provide in terms of training opportunities exist in other psychiatry departments and other practice settings. We did not have to invent all of the educational elements from scratch. Things like grand rounds and existing lecture series provide a lot of support within our program, and just took some logistics to match those with some additional education to kind of round this fellowship out. It has been critical in extending our pipeline to provide practitioners locally. Like I mentioned before, we've had additional nurse practitioner, physician assistants, doctor level psychology, marriage and family therapy, and social work students served by the same infrastructure during that time period. And 8 of those students have contributed effort at some point to those other consortium projects. All of our fellows since 2020 have contributed clinical effort to the consortium projects. And so the fact that we are able to kind of have that value add for really very little additional input, I think has been huge. Lastly, we have set a lot of this up to potentially be delivered remotely. Those educational and supervision elements could potentially be expanded to other systems like our community mental health system, the MHMR system in Texas, if there were places or funding that were particularly interested in setting up a similar program. And so we're excited to continue growing the fellowship and seeing how we can help other areas attract and train really quality providers. Any thoughts, questions?
Great work. No questions right now, but thanks for all the work that you're doing.
Thank you much. Thank you for your support.
Thank you so much. Next up, we have UT Health Houston, and we have Dr. Babatope presenting on their psychology training expansion and their social work training expansion.
Good afternoon, everyone. Okay, okay, you can hear me. Okay. Next slide. Okay. So the psychology internship program, we've had this for several years, but thanks to the ARPA expansion funds, we're able to expand our training program. So we currently offer 16 positions to graduate students in clinical school and counseling psychology. We are fully accredited, and it's a very highly competitive program. We receive close to 80 to 95 applications each year. Next slide. Over the years, we've expanded it to include tracks, the trauma track, adult inpatient, addiction, child and adolescent, and the developmental and assessment track as well. So for the child track, we have 3 FTEs. Next slide. FTEs where we continue to provide clinical didactics, group supervision, supervision of new and old cases, and also didactics. So some of the training that we offer is Circle of Security, which is an infant mental health intervention. We also offer training in PCIT, the parent-child interaction therapy, CBT, TFCBT. We also do some DBT and family coaching and supportive therapy with training, support, and developmental guidance. For the younger kids, we see from the ages 0 to 5, and we also see for the older kids from 0 to 17 for TFCBT. Since we started in July 2022 till date, we've been able to continue to train 3 interns each academic year, leading to 69 consistent training, 69 months of completed training for psychology interns. We met our target of 970 visits in February 2023, and we are continuing to provide psychotherapy visits for the kids that we see in the outpatient and the inpatient services. Next slide. So our current staffing is the 0.2 FTE for the project director, and we have our supervisors in the trauma, autism, and the child toddler track. And of course, we have 1 FTE for the interns. Our project coordinator is a 1 FTE. We have a CME coordinator and a contract and finance manager. Each month, we see an average of 200 sessions, patient visits. So far from September 2023 till date, we've been able to provide 1,800 sessions. Next slide. So what is our future goal here? We want to expand the internship program. We want to expand from 3 to 8, increase our engagement with our assigned areas, and actually introduce a new IOP, intensive outpatient program. Also, we want to increase the number of people we train Spanish to be able to provide services to the Spanish-speaking population, and of course, increase our retention of trainees in the state of Texas to improve access to care. Next slide. And these are just some of our faculty supervisors. We have Dr. Pearson, who is an expert in neuropsychology in the assessment of kids with ASD, ADHD, and also with our genetic disorders. We have Dr. Seema Jacob, who is our early intervention specialist. She's the one that provides parent-child psychotherapy and also PCIT and Circle of Security. We have Dr. Taylor, who is our trauma expert and also one of our leads at the Trauma Research Network. And of course, Dr. Oguero, whose specialty is CBT and DBT in the inpatient service. Next slide. So for our metrics, from inception to date, we've been able to train 17 total interns, 3 FTEs funded through ARPA, and we've been able to provide 102 months of total training. Each of our patients, we've been able to serve at least 542 patients, averaging 6 appointments per patient and more than 3,252 total appointments till date. Next slide. Do we want to switch to the
Why don't we go straight to the social work?
social work?
Yep.
Thank you. So as we continue to expand on CPAN and TChat, you know, we can't emphasize enough the need to be able to train our social workers. Just to buttress Dr. Williams' point, I think she shared a slide where there was a percent of sessions by participating providers, and we could see that psychiatrists were averaging 9%, and we could see LCSW, LMSW averaging 28% of those sessions. So increasing the training and providing support to them is very ideal for us at this point, and that is our number one priority. So the social work fellowship program that we started in July 2022, it's still pending accreditation. We're in the process of getting accreditation there, but it's to be able to support our LMSWs across multiple settings across the lifespan. Now, trainees are supposed to complete a minimum of 1,000 program hours, where 100 hours are dedicated to didactics and 900 to clinical practice, with 100 hours supervised. Next slide. Right now, we've been training 4 LMSWs each year, where we also provide clinical didactics and group supervision. Some of the other training opportunities we've been able to provide to our LMSWs are TFCBT, DBT, CBT, play therapy, and EMDR. Since we started in July 2022, we've been able to provide consistently 96 months of consistent training for the 4 social workers, and we've been able to serve 479 patients and provided 2,864 sessions till date. And this is as of April. I'm sure the numbers have increased by now. Next slide. And our current staffing model is a 0.2 FTE for the project director. We have 2 LCSW supervisors and 5 licensed master social workers that we are projecting for the fiscal year 2024 to 2025. We have our program manager there and our coordinators. And of course, we are hoping to be able to serve 598 individuals based on our last year's sessions, and of course, provide more than 3,000 sessions for the fiscal year 2024 to 25. So our goal is to expand to 5 social workers to train, but you know, for the 2026 to 2027, we're hoping to train at least 10 social workers. We obviously also want to include our new IOP program to one of their clinical rotation sites, and hopefully to be able to retain these trainees in the state of Texas. As some of you are aware, we have the School of Behavioral Sciences. And of course, we are located in Houston, so there's a great need right there. And so our ultimate goal is to be able to add these trainees to our workforce and to be able to deliver just optimal care to these kids. Next slide. And leading these efforts, we have Vanna Casimir, who's our supervisor of ongoing education. We have Shannon Hodges and Dr. Hamilton, who is an associate professor with us here. And just to be able to end here is that we've had this program since 2013. We had to close it down, but because of the ARPA expansion funds, we were able to get it back going. And we've been so grateful to have these funds to train these LMSWs at this time. So for now, we've trained a total of 8 interns. We have funded, we're funding 4 FTEs, and we've been able to serve 479 patients. And of course, a total of more than 2,000. Do you have any questions for me?
Thank you, Dr. Babato. Moving on to UT Health San Antonio, we have Christina Fields presenting on their professional counselor training expansion.
Thank you so much for allowing us to share with you some of the great work we're doing here. We have established through the ARPA funding what we call our We Care Clinic, Wellness for Children and Adolescent Restorative Empowerment, which serves as our LPC Associate Training Clinic. Slide, please. This is a no-cost hybrid mental health therapy clinic that offers services for children and adolescents 3 to 20 and their families. And this clinic came out of the need not only to equip licensed clinical therapists in our community, but also to serve as a referral resource for our consortium programs. We know CPAN, TCHAT, our research nodes are doing excellent work, but we often would find we would have kiddos that, for whether it was their location or insurance or some barrier, that we were not able to place them into community referrals. We Care, this clinic, is able to serve as a landing place for those children and their families. Slide, please. So this is just a picture of our structure. We have our 2 LPC supervisors who directly oversee our 8 associates. We also have 2 office receptionists because we are a hybrid clinic. We do offer those in-person therapy options. We really encourage education to our clinicians as far as what the needs are in our community. So all of our clinicians are trained in parent-child interaction therapy, which is that early intervention therapy for parents and their children. Of course, trauma focus, CBT, crisis response planning, and then clinicians are able to engage in different trainings that appeal to them. So we have some training in EMDR and RPT, as well as some additional trainings along the way. So here's a look at our metrics. We started last year in 2022. It took us a few months, of course, to get off of the ground. Last year, we were able to serve 251 unique patients. This fiscal year, we will well over double that. We are still not at capacity. We just brought on our last clinician, and so we're waiting for their template to open. And so we know we will well surpass our numbers and are really excited to see how many of these kiddos we are able to see from our community. This next slide shows just a picture of what this last fiscal year has looked like. So you can see we're steadily increasing in numbers by month, able to see these children and their family. The slide on the left is just that week-to-week breakdown, scheduled appointments versus completed hours. So most of our patients are showing up for their appointments. Next slide, please. And here's some additional interesting data that I pulled I think is important. We have seen a steady increase in the demand for in-person services. I think post-COVID, a lot of clinicians have gone hybrid or virtual. And so that's one of the highest demands or referrals that we see, is that parents and families want to be seen in person, especially for our younger population that maybe virtual is not a good fit for. And so we continue to see that demand grow. Those tend to be our first booked appointments, those in-person appointments. The graph on the right just shows how many appointments they attended, each of our patients. And so as you can see, that 4 to 9 sits at about 40%. Live in that range at this point. And then we have about 35% of our patients right now at 10 or more visits. So we have had, over these last couple of years, 20, 30 appointments, really showing, I think, that need of that walking along aside these families for, extended period of time. Can go to our next slide. It's a picture of our clinical team. We did do some anonymous assessments to get their feedback on how they're feeling. I think what we offer to them is very unique, and the training and the support that we're able to give them in hopes that once they graduate, they'll be able to go and be community providers that we are able to continue to refer to from all of our programs here at UT Health. So they're very pleased with, I think, the training and supervision that they're receiving. We continue to walk them through. We have a curriculum that they're dedicated to. They maintain a caseload about 50 to 60 patients. So they are very busy and they are maintaining hours. And we have our first, I think 2 or 3 that will be graduating and completing their hours to full licensures in the fall. So we're very excited for them. As far as the future vision, similar to what I had mentioned in the first slides, we developed this program out of what we see our needs are. And with our PeriPan program launching, one of the things we're finding is there's not a lot of referral resources for that population as well. And we want to be able to serve our providers who are asking for those referrals. And so through the We Care program, our goal is to start training our clinicians and get them certified through PSI, that we would also, if we're not able to find them those community referrals, that We Care would be able to see these families as well and these women to provide that support. And so again, I think the thing that we're excited about is that We Care is not only equipping and training these clinicians to serve in our community, but we're also able to support our current consortium programs at the same time. And I think that's it, unless anybody has any questions about what we are doing here.
Thank you, Christina. I appreciate it. Next, we have UT Southwestern. They have 4 different workforce expansion programs to discuss, and they'll be reviewing the women's mental health track, their advanced practice training expansion, psychology training expansion, and their master's and doctoral program. And this will be presented by Dr. Norcross.
Thank you. Slide, please. So the first expansion program I'd like to discuss is our Women's Mental Health Fellowship. We have had the Women's Mental Health track within our general residency for a number of years and have some excellent perinatal and natal psychiatrists to help oversee and provide care. So we are working to create a fellowship and have submitted everything and are waiting on approval from the Texas Medical Board. We anticipate obtaining that approval and beginning the training program on July of 2025. This will be a 1-year fellowship. Currently, the program is going to be directed by Mitra Dodi, one of our perinatal psychiatrists, who has done a lot of work in this area over the last decade and certainly has expertise to provide the oversight. The psychiatrists will be general psychiatry trainees recruited from actually anywhere, although we have interest from several folks within the state of Texas, and our goal certainly is to train folks that will want to remain in Texas. Areas that we're going to focus on in our rotations, which will happen through UT Southwestern, through Parkland Hospital, and through the PeriPan program, include reproductive psychiatry with some special populations, including child and adolescent patients under 18, correctional health. We're also going to heavily focus on trauma and some other prominent and kind of more challenging diagnoses for the for pregnant women, including eating disorders and addiction. So we're looking forward to getting our final approval and to start recruiting this summer and this fall and starting the program next year. Slide, please. Our Child and Adolescent Advanced Provider Fellowship, or APP Fellowship, actually started last week. This is very exciting for us. Our first fellowship class has 2 advanced practice providers in it. And this is a program that also started in our adult or general psychiatry program the year before. And we've been able, through the ARPA funding, to expand it into the child and adolescent arena. Our rotations, which actually aren't planned anymore, they are going to be the rotations that our fellows do, include some specialty areas in foster care, autism, addiction, eating disorders,
and Spark, which is our suicide prevention IOP for adolescents. And then they'll also do work in outpatient, our partial hospitalization program, and our consult liaison service. They will participate in didactics throughout the year and also have a project to do on an area of interest that they identify, and they'll do a presentation at the end of the year for this program. It is staffed and run by Mohsin Khan is our MD director, and we have two great APP program directors, Annette Mancuso, who is a nurse practitioner from our adult psychiatry program, and Lauren Esrock, who is a PA at Children's Health in the emergency room. We don't have APPs currently on our staff in the child psychiatry division. And so we have relied on the kindness and support of some APP providers outside our division. And this has actually, I think, given us a great overview and idea of what other services need from APP providers, as well as what we plan on doing in psychiatry. And our goal certainly is to add APP providers to our faculty within the division, and also in our upcoming campus state hospital. We are starting with 2 providers, and obviously we hope to grow this program as the state hospital opens up and additional training sites open up. And then we are going to pursue program accreditation through the American Nurse Credentialing Center. So again, we're very excited to have these 2 excellent trainees on our staff right now. Next slide, please. We are also starting up a Child and Adolescent Social Work Fellowship. We're hoping to have this start in the fall of 2024 with 2 clinical social work fellows that can begin their training. Rotations are similar to where our advanced practice providers are going to be, and include some of our specialty areas like foster care and the suicide prevention program, but also our transitional age youth program, some work in pediatric neurology in our emergency department to help with the mental health cases that come in through Children's Health, and then also in our PHP and IOP programs. We have a director, also very talented LCSW supervisor, Melanie Chung Sherman, who is helping us develop this program. And we, again, will be recruiting this fall. Additional support for education will be provided by LCSWs within the Children's Health and UT Southwestern systems in the different rotations. So I think that these fellows will be able to get a wide variety of supervision and kind of a nice mix of different people's training, and that should be very valuable. We do have the goal to increase to about 8 fellows in this program as it grows. And again, also we're going to pursue accreditation through the Council of Social Work Education. And next slide, please. And our 4th ARPA project is psychology expansion. We have training programs in psychology at UT Southwestern that provide services not only at UT Southwestern, but at Children's Health and at Parkland and out in some community locations. So we have a very broad experience for our psychologists in their training. So we want to, what we started with is expanding the clinical psychology class by 2 students, and that started last year in 2023. Primary partners include Children's Health, Children's Medical Center, where we have the students 20 hours per week, and at Parkland Health community-oriented primary care clinics, which are actually community healthcare clinics spread throughout Dallas County and provide not only medical care, but psychiatric care also. So they'll have the entire continuum of medical and psychiatric issues at both primary locations. The Director of Clinical Training at UT Southwestern is Richard Robinson. And we have an education coordinator, and then we'll have trainees working with children, adolescents, and their families. The future vision includes expanding the program to try to meet the growth of the need in Texas, and again, to the expansion of our partners at Children's and at Parkland and the new state hospital. And then we are going to move on to looking at postdoctoral training fellowship options too, and are discussing that currently with our psychology leadership to expand things even further. Thank you very much.
Questions for Dr. Norcross? Wonderful. Thank you, Dr. Norcross. Next, we have Texas Tech Health Sciences Center Lubbock, and we have Dr. Wakefield presenting on 3 workforce expansion projects: the APP training expansion, psychology training expansion, and the master's clinician training expansion.
Yes, and thank you. As I hear other people present, it sounds like we have about 6 projects wrapped into all of those things, but we have identified them in those 3 sections. So as a frame of reference, we've tried, because I think the Bradley Bogdan presented that it was difficult to recruit in their area as it is in West Texas. And so since the inception of all of our projects, we've tried to have a training focused model where we have in our TCHAT program, we have LPCAs. We have 16 LPCAs currently that are in a supervisory model so that we are providing access to clinical hours. So our entire structure of our program is oriented in that way. But as you know, it does take additional supervision and supervision time and didactic and learning time as well to do it in that model. We are also have a collaboration with our social works department over at Texas Tech. And we have, I believe, I was just getting the number. So a total of 8 social work students at the end of their graduate period who are doing practicums across multiple of our programs in CPAN and TCHAT and our PHP and IOP and in our outpatient settings. And so we have been able to expand that number. We started with 2, so now we're at 8, which is very exciting. We additionally have a mental health clinician training program where we are training licensed marriage and family therapist, licensed masters in social work, licensed professional counselor associates, in addition to what I described of those 16 that are working in TCHAT. We have 8 additional spots, 7 currently filled, hiring for an additional 1, who are working in an outpatient IOP PHP setting, which is very exciting. So learning those evidence-based models and increasing our workforce education out here in West Texas. Our psychology training, we have graduate level, our intern level, and our postdoctoral level. So for our graduate students, we used to have 3 spots. We've expanded to 10 spots. They're able to come into our clinical spaces, see patients, be provided expert supervision, someone watching that therapy that they're delivering and providing one-on-one supervision in a practicum setting. Then for our psychology internship, that will start in just a few days, July 1st. Dr. Mitchell can speak more about it if she wants to correct anything that I'm saying here, but has done the lion's share of getting this off the ground. It is now an accredited program. We have our site visit upcoming in September. We will have two psychology doctoral interns starting in July. So that has been quite a process to go through that APA accreditation over the last year. We have psychology postdoc program that we actually were able to start last year with one position. We had one position filled. We will have 3 positions filled starting in July. So we're really excited about that. Our entire area in the area of Lubbock had 0 doctoral internships for child psychology and 0 postdoctoral programs for psychology. So we are really excited to provide these. It greatly expands our educational opportunities and our ability to potentially retain those graduate students that are being trained at TTU in our area because they're not leaving. They don't have to leave. They can leave, but they don't have to leave for their internship and postdoctoral fellowships. Dr. Mitchell, anything else you want to add about the psychology training?
Nope, I think it's been a great area that we've been able to fill a gap for in our region. And I will just specify that our accrediting body will not allow us to say we're accredited until after that site visit. So the internship is soon to be accredited.
Thank you. Yes, thank you. As I was saying it, I was like, I think I'm misspeaking a little bit here. It's such an interesting process in the psychology accreditation process that we have to get our preliminary accreditation. That's probably not even the right term. Then match our interns and then have our site visit and then get final accreditation. So really excited to be in the midst of that process and appreciative of all the work that Dr. Mitchell has done. Finally, we have 2 advanced practice providers who have joined us. This is replicating a program that we had as a part of a district program many years ago in the Department of Psychiatry here at TCMHCC, where we had didactics and clinical opportunities for nurse practitioners and physician assistants. And so with this expansion funding, we were able to revive that program. And we're really excited to have that. You've heard a little bit about how these programs work already, so I won't belabor that. But I will say that with all of these initiatives, we are sitting at about 9,000 additional patient visits, seeing children and adolescents for our institution, which is really exciting. So this also, it's not only increasing the evidence base for our workforce that will leave us at some point and go out into the region and increase that evidence base of clinical services being provided, because many of these training opportunities would not exist in our region but for these funds. But it's also increasing our current service delivery. So we're really excited for that. And that's all I have.
Thank you, Dr. Wakefield. Any questions for Dr. Wakefield or her team? Wonderful. I know that at 1 o'clock we wanted to have Dell hop on, but it's perfect. 3 minutes early, but she is here and on time. So next we'll have Dell Medical School, Dr. Patel, present on the eating disorders specialty.
So we were fortunate enough to also expand our workforce, and we currently have an accredited internship site with 6 interns and 2 postdoctoral fellows prior to this expansion. Next slide. But we proposed that we were going to expand the opportunities for specialized training with the addition of 2 postdoctoral fellows. And really our goal was to increase access of care to our under-recognized and underserved populations. And specifically, we were looking at helping support youth with eating disorders and autism. Next slide. So these 2 fellows were operate here at Dell Children's Medical Center and really provide those specialized services of diagnostic assessments and evidence-based interventions, get the opportunity to work within a multidisciplinary team of professionals. They also are afforded the opportunity of teaching, as well as receiving high-quality supervision, but also providing supervision in a vertical model to our interns and externs here. With the additional goal of just being able to disseminate their clinical work through scholarly presentations and manuscripts. Next slide, thanks. So just a quick project status update. So they completed their year, both of these fellows, and they have made offers to join the faculty because they are extraordinary. Very excited to be able to have that. And also this funding allowed the faculty to have time to provide some of the specialty care supervision and training that we then used as an opportunity to do across disciplines, which I'll be able to share here in a moment. We also have 2 psychology fellows that will be joining us in the new academic year. Next slide. Thanks. So how we picked eating disorders, which many of you already know, but just a quick overview, 95% of individuals between the ages of 12 to 25 have an eating disorder. Post-COVID, hospital admissions increased significantly. Here in Texas, it was a documented 119% for children under 12. So huge need. But we continue to struggle, as we do across the state and actually the nation, with lack of specialty providers to be able to support and treat these kids. We were really feeling that within our hospital system, particularly. Next slide. So this funding was extraordinary in helping us to continue to develop an eating disorders training program. And what that looked like for us was having our faculty develop and implement a didactic series for our CAP residents and fellows that consisted of didactics that were, teaching the basics of eating disorders, really going into what evidence-based treatments were, looking at weight bias and stigma, having dietitian support and how to utilize that best. So really providing some consultation as well within that series of lectures. In addition, for our specific psychology-focused individuals, which was a psychologist, a postdoctoral fellow that I'm highlighting here, but also an intern and extern, and a social worker, there was a 16-group supervision didactic and a more novel approach of evidence-based treatment called temperament-based therapy with support, which really helped them not only to receive the information, but also to implement it through a live consultation series, increasing our ability to support this once these trainees continue on. And finally, having this time for our faculty allowed the creation of a new eating disorders focused practicum site at UT for the school psychology extern. So really being able to not only highlight this area for individuals, but create additional training opportunities that are so valuable in disseminating this knowledge. Next slide. Our fellow herself was able to see in this year an additional 42 patients for treating with eating disorders specifically, and also composed of 413 visits with supervision and support. The other area that we had a postdoctoral fellow placed was in developmental pediatrics. And as many of you know, autism is one of the most commonly diagnosed neurodevelopmental disorders, with 1 in 36 in the United States. In Texas, it's 1 in 28 kids presenting. We also know that early identification and treatment of ASD has a higher likelihood for improvement of symptoms. But the challenge is that we have a shortage of providers again, and that results in delayed care. Within our hospital system, it can be up to 9 months of a wait. And so that can be very challenging for families. Next slide. So with the support of our postdoctoral fellow and our faculty specialists, they were able to develop a screening process through Project Access, which was supporting pediatricians in identifying signs of autism, or maybe if they suspected it, and then they could make a direct referral to have a comprehensive evaluation to then help those children and those youth, if identified positively, get those services earlier rather than being on a wait list. As well as seeking for older children that might have been missed. Project Ocean was another project that was created with the support of this fellowship and helping identify autism and neurodiversity with our school-age children. in a kind of quicker way than, in addition, if they were fast-tracked or identified as being able to be seen. Our fellow also was able to do evidence-based interventions specifically for children with autism, including the Ruby parent training, which is a very specialized training, PCIT, and using other CBT techniques and therapies. So this was a really great to have another clinician to be able to provide this within our system. And we were able to, this postdoctoral fellow will be joining us for faculty. So we're very excited about that. Next slide. He was able to see 146 patients for assessment and treatment and provided 379 clinical visits. So our future vision, just with the addition of these 2 fellowships, we were able to make an impact that felt like lasting difference. And we'd hope to continue to expand that from 2 to 3 and also be able to support a psychology intern in our growth. One of the things that this funding has really done is be able to provide investment in training to be able to create these opportunities, not only for these specific trainees, but also be able to support training for all of our just hospital individuals and trainees across the system that can benefit from these created curriculums, and also continuing to help support our continuum of care within our different locations. So we have, our fellows and residents in the hospital, but we also have our outpatient clinic, and these didactics have helped us create a bridge between our different settings and support for our faculty to kind of oversee overall how people are doing. Great. Thank you so much. I don't know if there are any questions.
Wonderful. Thank you, Dr. Patel. All right, I am going to give some verbal updates for the remaining HRIs and projects. It looks like we only have 1 slide and we're going to go over 8 more. So everyone, please bear with me and we can get to questions at the end of these 3 HRIs if there are any. Just as a heads up, I believe last executive committee meeting, we discussed some contract delays, reviewing how that impacted starting operations with many approvals and finalizing of contracts coming through around March 2024. So please keep that in mind as we go through some of these newer projects. And also keeping in mind that some training types join at a particular point in their educational journey, like psychologists, and that follows some strict timelines that might require some adaptation to the project. So the first HRI I'm going to give an update for is Baylor College of Medicine. And the slide that you're going to see in front of you is the resident rotation in child and adolescent psychiatry at the Harris Center. The primary lead for this project is Dr. Lindsay Pershern, and she is also the director of residency training. This project is ongoing in resident rotation in child and adolescent psychiatry at the Harris Center, where PGY3 residents are working in an outpatient clinic for half a day a month for 1 year, and they're being supervised by Dr. Felicia Gardner at a 0.5 FTE in funding. There are no anticipated changes throughout the biennium, but we are looking at some barriers and limitations due to Harris Center not being able to accommodate more trainees in the program at this time, and looking forward to expansion. That should be it on that slide. In addition, following along that addictions branch, but focusing on a couple of different workforce subspecialties, we have the addiction specialty at Baylor led by Dr. Daryl Shorter. This project focuses on training LCDCs, professional counselors, peer support specialists, psychiatrists and psychiatry residents trained or becoming trained in substance use. Due to those contract and funding delays, the project was not viable in this fiscal year and is not currently operation. But in regards to future vision, we're looking at where these resources could possibly assist with the TChat 2.0 or substance use services programming within Baylor College of Medicine and their catchment area in the next biennium. Next, under Baylor College of Medicine, we have the Psychology Training Expansion Project led by Dr. Eric Storch. This is an existing program from last biennium. This one is on track since last fiscal year, and they've been able to train up to 4 trainees at any time. What they are doing as part of this project is providing training and supervision for those psychology fellows. And in fiscal year 24 so far, they have been able to provide over 1,000 appointments. And it looks at this time, they have approximately 6 trainees, and that might ebb and flow, but up from last year. Also under Dr. Storch, we have the social work training expansion. This project is on track as well. Very similar to the psychology project, training and supervision are provided. There was a lapse in supervision as a supervisor went under leave, and there was some readjustment in the staffing model, but we are back up with social workers being added to the program, training being scheduled for June, and there was some training in May, and the official supervision will recommence in July. We had a new supervisor join that team so we can increase the number of licensed clinical social work trainees to 11. The program saw a 20% increase in clients seen and 37.8 increase in completed return visits compared to March. While this program continues to address challenges with patient flow and the start of the supervision didactic series. In addition, they have been able to provide 200 pediatric appointments in fiscal year 24 and are supervising around 20 trainees at a time. 2 more projects with Baylor under the lead of Dr. Storch. We have the Teen Health Clinic, which can provide some hybrid and in-person services and experience with trainees for children and adolescents. This is a new project for the biennium, and they have been able to provide 300 pediatric appointments and currently have 3 social work trainees. And then finally, the master's and doctoral program, which is in the development phase. This is a long-term project, and we will see a majority of the effort and outcome in the next fiscal year. Baylor has been able to onboard their full-time faculty member to lead that program development and hire a part-time research coordinator to assist, and has been able to provide them with an offer. The next HRI to provide an update about is the Texas Tech University Health Sciences Center, El Paso. The primary lead on the psychology training expansion project is Dr. Sarah Martin. We have seen, similar with other projects, some contracting delays. This is a project that has been viable since last fiscal year. In fiscal year 2023, they met all of their goals with almost 900 pediatric appointments amongst 2 trainees. We were unable to meet the timeline for the psychology fellows in this fiscal year, but next fiscal year, we'll anticipate a start for a new psychology training program set of trainees. And finally, the last project for an update comes from the University of North Texas Health Sciences Center, with the primary lead being Dr. David Farmer. They are engaging in the master's clinician training. We are working with the Office of Sponsored Programs to move forward on that contract being fully executed, which happened at the end of March. All of the project IDs and strings have been created and those positions have been posted, and they are working on hiring and training social workers and professional counselors that can be brought on anytime throughout the duration of the project. So those are the remaining workforce projects. Any thoughts, questions?
Just a couple of quick comments. Obviously, a lot of work taking place with the ARPA funds. And again, congratulations for the institutions. It really sounds like in several instances it's filling a need, and then filling gaps in the teams for their CPAN, TCHAT, et cetera. And so I think that's a good message. As we've talked in the budget meetings, a lot of these workforce initiatives, we will need to have authority and a rider. And so there'll be a lot of work that we need to do over the next month, over the next several months, to highlight what has worked, what hasn't worked, and figure out kind of what the next step is for each of these and opportunities. And probably need to put some of this into a summary document that gives a easier perspective of looking at it and seeing the investment and the return on the investment for each of these initiatives. But again, thanks everyone for the work to put these in place. Carol, I see your hand. Carol, you are on mute, my friend.
I just want to say I'm bowled over, David. This was just wonderful. There's workforce development going on all through the state in every one of the HRIs. I just think it's wonderful.
Well, thanks, Carol. Again, I think the challenge for us is to figure out how do we communicate that and put that into a document to show the breadth from El Paso to Dallas to Houston, down in the valley, et cetera, related to all this work that's taking place and how it's really filling that need for those areas of the state that, and Sarah, I'll go to you, but having the ability to train individuals in your community so they don't leave your community and never come back to your community is really important. Sarah?
Yeah, I mean, you stole the words right out of my mouth with that last statement, Dr. Lickey, but I think that's why we are uniquely positioned to do that as HRIs, is that we are in a training mission. But for us to be able to have, especially and I think all across the state, there's not an area of the state that has enough mental health clinicians. But we feel like we uniquely feel that additionally in some of our regions too, that creating the ability to create these and the privilege to create these programs is allowing us to compound and multiply exponentially our impact across these programs. So just wanted to amplify that again as we have this conversation, and in any way we could put that together to become even more compelling, I would be happy to participate in that.
Oh, that'd be good. Again, workforce is going to be a big issue, I think, this session. And again, just be ready that we need to be, we're going to be asking you guys questions and making sure that we can summarize this in a way that is easy for the legislature and others to see. We're not going to be able to spend an hour with the legislature going through each of these initiatives like this, but we need to summarize it in a way that they see the return of the investment. Carol?
Just let us know what you need. I mean, I think there's a whole lot of interest and enthusiasm. And, people do this with pictures in clever ways, not me, but but there are people who are talented to do that. So
Yeah.
We'll think about it at our place and send you any good pictures that we have.
Yeah. And I think some of those cross-cutting themes, again, how they are not only training at your university, but then how do they fill in those gaps that you've had in these programs is a message that we need to. Something I heard from the A&M presentation, but also in Sarah's and several other presentations. All right. Very good. Thank you, Sarah. The last item that we have, Alex, let me turn it over to you. Want to touch briefly on the budget, about kind of the process, not the final budget, but we are doing a lot of work right now trying to make sure that we get the budget right as quick as we can. And there's two components. There is this biennium, but also thinking through for the next biennium. And so, Alex, let me turn it over to you to guide us through the thought process, okay?
Yeah. So as Dr. Lakey mentioned, we have two pieces here, the FY25 rebudgeting exercise, as well as the FY26-27 biennium preliminary requests. So far, all of those first drafts have been submitted by our HRIs. We've had all of our budget meetings. There was extremely helpful discussion and collaboration coming out of those meetings. And of course, it was also a fantastic opportunity for us to see what kind of patterns we're seeing across the HRIs. So following these discussions, we requested resubmissions based on efficiencies that we may have discussed during the budget meetings. And so I have the majority of those turned in. We still have a couple outstanding, and more than likely, these will be what we base our budgets going forward. Next slide, please. Okay, so following this, in the next 6 weeks or so, like Dr. Lakey mentioned, we're aiming for September, and I plan to present a more comprehensive view of the budget in next month's EC meeting. But as we could continue to work on these budgets and refine them with your input, then we'll have a better idea, like I said, going into the biennium. We haven't touched on research budgets quite yet. We will be working with our research teams and should have a meeting on the books here pretty soon to get those pieces started. And following all of those type of meetings and discussion that comes out of that, we'll be able to come back to you all for the development of those budgets, not only for FY25, but 26, 27 as well. And then, as Dr. Lakey mentioned, of course, earlier today as well, that we have this option of additional research funding of up to 2.5 million to be brought into NECMR. And so that, of course, would also be brought back to the EC. Next slide, please. Okay, so we just reviewed some ARPA initiatives. Dr. Lakey touched on this a little bit, but as you all know, the funding for ARPA will go offline in May of 2025. And our plan at this moment is to request to continue these services on the interest that has been generated over these last few years on the ARPA funds. And of course, again, as Dr. Lakey mentioned, these initiatives, we may or may not have the legislative authority to continue. And so those would be pending any kind of rider or some kind of legislative authority to do these things. And like I said, hopefully next month we'll have this comprehensive budget presentation. And I think that's it for me. Any questions?
So again, thanks to everyone for being parts of these meetings. So they're basically 2-hour meetings we've had with each of the HRIs to go through. It's been an hour on the current biennium and an hour on the second biennium. There hasn't been one budget so far that after that, everyone thought it was exactly the way it should be. And so again, appreciate each HRI going back and looking at items. As I've discussed with each HRI, is better that for us to have a hard look at those than to just take them and then having that conversation with the legislature and having them push back. And so again, it's a process. We're going to look at all these new budgets. There may be some additional conversation, again, we just need to make sure we get it to where we feel very comfortable that if I had to lay out each individual budget before the legislature, they would understand why the increased funding would be needed. We need to make sure that we can show them that we've been the best stewards possible with the funds, and that we've sharpened our pencil, and that the budgets are as close to right as we can now that we're several sessions in. And again, for the current biennium, there's several important things that are funded through ARPA, and we're going to need to prioritize them because of a little bit of a gap in length of when ARPA goes away and when the next session dollars go. And we really don't want to drop in Perry Pan. We don't want to drop in all these other initiatives, and make sure that we get them funded all the way through the next session. On the workforce, we're going to need to get rider authority for the ones that are not just kids related, and the ones that aren't psychiatrist related. And so we'll be working with your institutions to figure out what that rider will look like. But there's several that, if you look at the statute, we'll need to have some additional authority. We had the authority because of the ARPA and the riders in the ARPA, but we'll need to have new riders on the base budget this next session. So I'm happy to answer any questions, but again, just want to let people know we appreciate your availability, and we're trying to be as transparent as possible as we look at the numbers and try to justify the budget request from each university. Any questions? All right. Thank you, Alex. Is there anything else you needed to say, Alex?
No, that's it. I just say that I echo your words saying I appreciate you all working with me, and I've had a great first experience with you all. Thank you.
Alex has been doing a great job keeping us organized, so thanks. All right. With that, I think we're at the end of the agenda. Is there anything else that we need to talk about that's germane to the items that we've put on the agenda? Hearing none, seeing none. Thanks, everyone. Thanks to those that are in this room for being here today. And look forward to continuing to work with you over the summer. Thanks, everyone. Bye.
Thank you.
Thank you.
Bye, thank y'all. Have a good week.
Just made.
You said you were 1:30.
Yep.